I think we'll start if that's fine with all the speakers. Okay. So a very good evening to all of you. On behalf of the Indian Academy of Neurology and the Autoimmune subsection of the Indian Academy of Neurology, I welcome all the eminent speakers and all the colleagues who have joined online for this webinar. This is in continuation of the previous webinars that we had started, which would cover a range of different understanding of various disorders. We have covered some basics before and some clinical features before, and today's webinar is an important webinar as it covers a lot about disease modifying therapies. It also covers about biological agents, how to do a checklist, and how to plan vaccination and concerns of infection for people who have to be treated with various DMTs, especially the stronger immunosuppressants. And then we will talk about an important topic of transitioning from one drug to the other, and what are the concerns and how do we make those decisions. Dr. Netravati may not be able to join for some home emergency, but in case it is possible, she will join. So I welcome the first speaker, Dr. Shruti, who's a friend and a colleague and a professor of neurology at Sri Chitra Institute of Institute of Medical Science and Technology at Trivandrum, Kerala. She has been supervising postdoctoral fellowship in neuromuscular disorders and also is a member of the technical committee for her state for MS and has a profound interest in this subject. She has been a recipient of the MS International Federation grant in 2019 and also been awarded awards for many of her commitments towards the field of neurology and the field of neurophysiology, and is one of the close collaborators for us for the Indian MS registry. So Dr. Shruti will be speaking about an important topic about disease modifying treatments. What are the types, adverse effects, and how do we monitor? Something that we need to know in day-to-day practice for MS and allied disorders. So welcome, Dr. Shruti, and please take over.
Good evening, everyone. Thank you very much for the introduction. I will straight away go to my talk. So I'll be speaking on the various disease-modifying therapies which are available for the demyelinating disorders of the nervous system.
Can you raise your volume?
Okay, can you hear me now?
Yes, now it's perfect.
Oh, thank you. So we have an array of disease-modifying therapies which are available for the various nervous system disorders. Broadly, we can see them as MS-specific therapies, and those therapies which are useful for the rest of the CNS demyelinations like NMOSD, MOGAD, or seronegative demyelination. Now, MS-specific therapies usually have a very narrow spectrum, and particularly if you think about the moderate efficacy therapies or the platform therapies. And some of them have the propensity to worsen the clinical status in non-MS demyelination, so that the use of MS-specific therapy should be confined to those conditions where you're sure about the diagnosis. So my task today is to speak about the non-biological agents, and the second talk by Professor Thomas would deal with the biologicals which are available for treatment of both MS and non-MS demyelination. The MS-specific immunotherapies are broadly classified under the injectables, orals, and the infusion therapies based on how they are given. Currently, we have more than 20 agents available, and in India, we have more than 12 or 13 of them, which can easily be accessed. The injectables which are given either subcutaneous or intramuscular injections are the interferons, peginterferon beta, and glatiramer acetate. And one of the biologicals, ofatumumab, is also given as an injectable therapy subcutaneously. The oral therapies are dimethyl fumarate, teriflunomide, S1PR modulators, and cladribine. And all the monoclonal antibodies are usually given as infusions except for ofatumumab. So what I'll be speaking on today are the non-biological agents, which are either the injectables or the orals. Now, these medicines were some of the earliest medicines which came for MS therapy. Interferons were the rulers from about 1993 to around 2010. The major drugs available were the interferons and glatiramer. In between, Tysabri and Natalizumab was introduced, which was useful for highly active therapy, but was very costly and available only in certain, could only be given for a certain specific population in our country. From 2010 onwards, there was the age of the oral therapies. The first one to come was Fingolimod, but the first one to actually come to India was dimethyl fumarate. Along with that, we had teriflunomide. Now, uh, with about 2015 onwards, we started using Rituximab in India for highly active therapy, and I think that is a staple for most of our MS therapy right now. S- Um, the mechanisms of action of these DMTs are widely variable. Most of the moderate efficacy agents, such as interferon and glatiramer, and also dimethyl fumarate, have multiple effects or pleiotropic effects, whereas teriflunomide acts by reducing the proliferation of the lymphocytes. Some of the cytotoxic agents, such as mitoxantrone or cyclophosphamide, also act by this mechanism. Specific targeting of certain cell populations is done by alemtuzumab, rituximab, ocrelizumab, and cladribine, whereas natalizumab and S1PR modulators act by blocking the entry of lymphocytes either into the central nervous system or outside of the lymph organs. So you can see that those with act by pleiotropic mechanisms generally have a moderate efficacy, whereas the targeted cell lysis and anti-migratory agents generally have a highly effective action. We come to each of them individually. Our main task is to look at the mechanism of action as well as the side effects and monitoring. I will not be speaking too much about their efficacy, which I hope will be covered in some later webinars. So interferons are naturally occurring cytokines, of course, which occur within our body. They are broadly classified into 1, 2, and 3 interferons. The type of interferon that is used in MS is interferon beta, which comes under the type 1 interferon. And the effects of interferons are mediated by the interferon stimulated gene products. Now, how this medicine started to be used in MS was by the observation in the murine model of MS, where intrathecal injections of natural interferon beta were shown to have a protective effect and reducing the exacerbations. Also, the immunomodulatory functions of interferons uh, could be shown by uh, both in vivo and in vitro actions could be shown by different mechanisms, including the inhibition of interferon gamma synthesis, which is pro-inflammatory, augmentation of suppressor activity, and inhibition of class 2 MHC expression. Now, as I mentioned, there's not a single mechanism by which interferon acts. It prevents the activation of T cells and basically shifts from a pro-inflammatory milieu to an anti-inflammatory milieu. It reduces the inflammatory cell infiltration across the blood-brain barrier and brings back the protective regulatory cell activity. And it's recently understood that it may also be having a majority of effect by influencing the memory B cells by reducing their function, which are important in the physiology of MS. We have many different formulations of beta interferons. The first one to be introduced was interferon beta 1b, which is otherwise initially marketed as betaferon. It is given 250 microgram every alternate days as a subcutaneous injection. The one which is very commonly used is intramuscular interferon, that is Avonex. And also there are biosimilars in other companies. It is given as a 30 microgram injection weekly. Another common interferon is given as 22 microgram or 44 microgram every 3 doses per week. And that is a subcutaneous injection. So we have two types of interferon beta 1A, which is given intramuscularly once a week, and one which is given subcutaneously thrice a week. And we have one formulation of interferon beta 1B, which is given subcutaneously on alternate days. Now, after about 2 decades of the interferon being introduced, they introduced a pegylated form of interferon beta 1A, which is to be given once every 2 weeks, and that too given subcutaneously. And the dose is 125 microgram every 2 weeks. And the advantage was that there was fewer number of injections to be endured by the patient. Now, the main problem which was noted with the interferon injection was flu-like reactions and the injection site reactions, which occurred in nearly up to 70 to 80% of the patients. And for the first 3 to 4 months, when we are giving interferon, mostly we need to give additional paracetamol about 1 to 2 hours prior to the injection, and for probably the next day as well, they may have to continue the paracetamol. And you usually ask the patient to take hydration, and the injections are preferably given on a day prior to a holiday. So usually we give it on Saturday evening so that the next day the patient is able to take rest if required. So this is pretty common for the first few months, and many patients, these symptoms come down after the first few months. There is also uncommon side effects such as elevation of liver functions. There is more report of depression with interferons, and this is a major problem with MS where depression can coexist with the disease itself. And thyroid function also has to be monitored because there's the risk of autoimmune thyroid dysfunction. Now, neutralizing antibodies can occur in about 5 to 45% people within 2 years of therapy, and that is something which led to resistance to interferon therapy in many people. And the pegylated interferon group was useful in improving this side effect. Now, coming to the next injectable, which is glatiramer acetate. This was actually a synthetic molecule produced by the combination of 4 amino acids into random molecules with leading on to a polyamine, which was about 40 to 100 amino acids in length. Now, the entire thought behind was that this is an analog of myelin basic protein, which is a component of myelin. And because it is an analog, it competes with the other myelin antigens, and preferentially it binds to the MHC class 2 molecules and diverts T cell responses away from the myelin antigens. And it also shifts the inflammation from a pro-inflammatory to an anti-inflammatory phenotype, and also has some protective and neurotropic functions as well. Now, this is given as a daily subcutaneous injection. Initially, it used to be just 20 milligrams subcutaneous. They also tried different frequencies and different, alternate day regimens of either 20 milligram or 40 milligram, which were also found to be equally effective. The major side effects related with this was the injection site reaction, and over multiple times, it will lead on to local lipoatrophy as well. About 15% of patients would complain of acute breathlessness, palpitations, and a flushing reaction, which was an idiosyncratic post-injection reaction which subsides on its own. And it is not a typical allergic reaction, but this led to discontinuation of the drug in many patients. The most important advantage of glatiramer is that it does not cause any end organ damage, does not require any particular monitoring. It is one drug which has considered level B in pregnancy and can be continued before as well as throughout the course of pregnancy. Now, the problem is with both interferons and glatiramer is that they are given as injectables and they are given very frequently. They often leads to injection fatigue, as well as patients develop some fear of injections over time. Their efficacy is also low compared to the newer agents such as Rituximab and other monoclonal antibodies. So currently, we have specific regions where we can use these agents. So they are not generally preferred as first-line agents, except in those patients who are especially risk averse. We have a long history of using these medicines, and we know that even after 30 years of use, there is no long-term side effects such as end-organ liver or renal damage or reduction in immunity. And those who desire of pregnancy and lactation may also prefer to move on to interferon or glatiramer. Those patients who are stable on interferons or glatiramer, we prefer not to change the medicine because sometimes changing them to even a better agent may not work as well as continuing the previous therapy, and it is very important for the patient happiness as well. If they are intolerant to medications, particularly with regard to having recurrent infections, these are a good group of medications. In fact, interferons were specifically preferred during the COVID-19 pandemic. And when we want to de-escalate, although the preferable agents are oral agents, interferons are another group when there is some risk of immunosuppression. And of course, they are used as active comparators in many clinical trials, especially like alemtuzumab and ocrelizumab. We come to the next medicine, that is a dimethyl fumarate. It is an oral agent. there are three fumarates that are available in the market, but only one is available in India. So dimethyl fumarate is available in India, but you also have its precursor monomethyl fumarate and a new agent diroximel fumarate. It acts again by pleiotropic mechanisms. It activates NRF2 pathway and has two functions. It acts in the periphery to change the suppress the inflammatory T and B cells as well as the cytokines, and increases the Th2 anti-inflammatory pathway and the B regulatory pathway. In the brain, it has a direct activity to enhance the cellular response to oxidative stress and to prevent neuronal loss. It is given as 240 milligram twice a day. You have to start with 120 milligram twice a day, and then after 1 week, increase it to 240 milligram. This was a dose for the original molecule. The generic molecules which are or the biosimilars which are widely used have a tendency to produce more of GI side effects, and sometimes we give it even slower. So I usually start with 120 milligram once a day and then increase every week to 240 milligram twice a day. A 120 milligram twice a day dosage is also acceptable, but it has lower efficacy compared to the full dose. The adverse effects which are very commonly seen are the GI symptoms which occur in the first 2 to 3 months. They tend to have gastritis and diarrhea, and flushing episodes where the patient feels as the face becomes red and hot. So that lasts for about 10 to 15 minutes, and this can occur multiple times in the first 2 to 3 months. Most of my patients continue to have this even after the first 2 to 3 months. Now, the GI symptoms can be mitigated if the drug is given along with food. If possible, you have to give a proton pump inhibitor in the first 2 to 3 months. And slow titration can also avoid the GI symptoms. Flushings which are producing a significant discomfort for the patient can be treated with aspirin. The immunological problems which can be caused by DMF is related to the fall of lymphocytes. So about 30% of patients experience some fall of lymphocytes, but a small subgroup can have a significant fall of less than 800 per cc of lymphocytes, and a persistent reduction of lymphocytes of less than 500 for more than 3 to 6 months predisposes the person to have PML. Although the numbers are very, very few, if the patient continues to have persistent lymphopenia, the medicine may have to be changed. The newer medicine, that is diroximel fumarate, the basic advantage is that it has fewer side effects, but is otherwise comparable to DMF in all other functions. Now, the next drug is teriflunomide. So this is an anti-proliferative agent. It inhibits the mitochondrial enzyme dihydroorotate dehydrogenase and thereby inhibits the pyrimidine synthesis pathway. And it then thereby reduces the T and B cell proliferation, thereby inhibits the inflammation caused by related to MS. Now here, it does not usually produce significant lymphopenia, and it is not a significant immunosuppressive agent, but there have been cases of TB and sepsis that have been reported. So the patient has to be screened a priori for presence of tuberculosis. And if the patient has active infections, the medicine may not be given at that point of time. The preferred dose is 14 milligram per day oral, but a lower dose of 7 milligram per day is also available. It is a metabolite of an anti-rheumatic agent, leflunomide, and because of that, the teratogenicity of this agent is well appreciated. I'll come to the details in the next slide. So the major or most common adverse effects that are noted are the presence of headache, some elevation of hepatic transaminases, GI side effects like diarrhea and alopecia, and most of these occur in the first 3 months of giving the medicine. But you also need to monitor the blood pressure because they can develop hypertension, peripheral neuropathy, and rarely severe skin reactions such as Stevens-Johnson syndrome. Acute hepatic failure is a significant risk, which in the sense that it is a fatal risk that can occur, and that needs to be monitored through the monitoring of liver function tests. Lymphopenia, as I mentioned, is infrequent, but when it occurs, it can predispose the patient to infections. The major understanding we should have regarding teriflunomide is that it is a highly teratogenic agent and should be avoided in patients who are planning pregnancy. And the problem with the medicine is that Whereas for most of the other agents, you need to stop that medicine only for 1 to 3 months prior to conception. This drug has a long T-half and has to be stopped 2 years prior to planning pregnancy. Now, since that is not a viable thing to do, an accelerated elimination is required for most patients to bring down the serum values of teriflunomide to the desired level of less than 0.02 milligram per liter. So there are two agents which can be used, that is cholestyramine, 8 gram thrice a day for 11 days, or you can use activated charcoal, 50 milligram, 50 grams twice a day for 11 days. And at the end of the accelerated elimination procedure, the blood levels have to be rechecked. And only if it is less than 0.02 should they go ahead with the planning for pregnancy. And the second important point in teriflunomide is that males are should also avoid the medicine because it may be secreted in semen, and if the person is planning to have a family, it is contraindicated in males as well. Now, the next group is simcosin 1-phosphate receptor modulators. So, simcosin 1-phosphate is a widely distributed signaling molecule, which is there in the central nervous system, lymphocytes, heart, smooth muscle, and endothelial cells. In the lymphocytes, the signaling helps in the trafficking of the lymphocytes between the blood as well as the lymphatic organs. So, in a normal situation where there's a peripheral inflammation, the S1P signaling is activated and the lymphocytes move from the lymph node organs to the periphery. When the modulators are given, it causes internalization of the receptor and the lymphocytes are trapped within the lymph node organs. So the peripheral lymphocyte count usually falls greatly, and even up to the level, an absolute lymphocyte count of 200 micromoles per liter is normal. So you have 4 molecules that are approved for among the S1PR modulators. The one which we have in India is fingolimod, which is given as a 0.5 milligram single daily dosage. It's a non-selective agent. The second generation ones are more selective, which are siponimod, ozanimod, and ponesimod. All these are given as single doses, and they have less propensity for cardiac as well as hepatic side effects compared to fingolimod. The major side effects associated with this are, as I mentioned, lymphopenia can occur, but no action is required unless the absolute lymphocyte count is less than 200. Hepatic injury is a common side effect of all the S1PR modulators. There is a high propensity for infections, and there can also be intracranial infections such as herpes encephalitis. Skin malignancies are a risk which need to be monitored. PML has been also reported in both siponimod and fingolimod, and the duration of treatment beyond 2 years seems to be a factor which is associated with that, and older age of the patient is also a factor which increases the risk of PML. There is a risk of first dose bradycardia and heart block, and the risk of macular edema, both of which require monitoring. It is a teratogenic agent and should be stopped at least 1 to 3 months prior to planning conception. And since this is an agent which just blocks the lymphocytes, when you stop the medicine, there is a risk of rebound activity. And the next medicine should be started within 8 weeks of stopping fingolimod. Now, fingolimod has the highest toxicity of them all. So the first dose should be monitored for first 6 hours for any bradycardia. And ophthalmology evaluation for macular edema should be performed every 3 to 4 months. And liver function tests at baseline, monthly, and every 3 months thereafter should be performed. For the rest, siponimod, ozanimod, and ponesimod, only those people who are more likely to have a heart problem and those which are at a high risk for ophthalmology evaluation need strict follow-up. And the last drug in this group is cladribine, which is a deoxyribonucleic analog and selectively acts in the lymphocytes because of the presence of high kinase in them, which can activate the drug in the intracellular region, in the intracellular milieu, whereas the uh, other cells do not have this kinase activity and are not affected by the presence of cladribine. Now, this is one of the immune reconstitution therapies, which means that it has to be given only for a specific period of time. So, cladribine is given for 2 years. For the first year, you give the first month and the second month for the medicine is given for 4 to 5 days. And then the year 2, again for 5 days, in the first month and second month. And that thereafter, there is no further dose of cladribine that is given. And with this therapy, more than 50% of patients continue to maintain the ADSs as stable uh, for more than 5 years. I'll skip this medicine. So, compared to the other immune reconstitution therapy, that is alemtuzumab, cladribine produces depletion predominantly of B cells compared to the T cells, and there is no risk for an autoimmune disorders such as thrombocytopenia or thyroid dysfunction, as is seen with alemtuzumab. And the reason is that the T regulatory cells are not depleted to the extent that it is done in alemtuzumab therapy. So there are fewer opportunistic infections as well, because whereas alemtuzumab produces depletion of both innate and adaptive immunity, only adaptive immunity is affected with the cladribine. So the side effects are very few in spite of this being a cytotoxic agent. So it produces lymphopenia, alopecia, skin reactions, uh, milder upper respiratory infections and herpes infections. It is contraindicated if the patient has active tumors and there is a increased occurrence of uterine leiomyoma that is seen with cladribine. Now, all of these agents have lower efficacy compared to the monoclonal antibodies, which we discussed in the next talk, and these have to be used. Their role is primarily as in patients who have moderate uh, disease activity, or when we are planning for de-escalation, because the newer paradigm is shifting to a early, highly effective therapy regimen. How to monitor? Interferon beta the monitoring is for blood counts, LFT at 1, 3, and 6 months, and then every 6 monthly, and thyroid function every 6 to 12 months. Glatiramer does not require monitoring. Dimethyl fumarate requires monitoring of the blood counts and LFT every 3 to 6 months, and more frequent monitoring if lymphocyte count is less than 800. Teriflunomide requires monthly LFT for 6 months and blood counts and BP monitoring. Fingolimod requires cardiac monitoring when it is started, ophthalmological evaluation every 3 to 4 months, and blood counts for after 1 month and then every 3 months. Cladribine, every 2 to 6 months, the blood counts, lymphocyte count, and the LFT has to be monitored. Now, very briefly, I'll mention the non-biological therapies for NMOSD and MOG, which include azathioprine, MMF, methotrexate, and some of the cytotoxic agents such as cyclophosphamide and mitoxantrone. So just starting with glucocorticoid, which is used mostly as an acute and a bridging therapy, and it is not ideal for long-term maintenance because of the massive risk of side effects. The important point to remember is that the rate of tapering of glucocorticoid agent will depend upon the steroid-sparing agent that you are using. So you need to continue a high dose for the first 3 months. By the time the medicine takes effect, you may start tapering either rapidly or slowly, depending upon the alternate agent that has been used. And you know the very widespread issues related to the use of glucocorticoids. What you need to monitor, of course, blood, BP, glucose, electrolytes, and lipid profile have to be monitored. The first 3 every 2 weeks to 1 month, then the other one every 3 to 6 months. Eye examinations for cataract and glaucoma every 6 to 12 months, and annual DEXA scan has to be given. In addition to proton inhibitors or H1 blockers, you require calcium and vitamin D to be supplemented, or they should be maintained in the normal range. In high-risk patients, bisphosphonates should be added. A single morning dose is the recommended one to go along with the biological clock of cortisol secretion. Alternate day regimen can help with adrenal insufficiency, and they have to be informed about a need for higher therapy during infections or during stress. And those patients who have other risks, such as older patients, those who have HIV infection, or those who have more than 2 other immunosuppressants, you may have to give prophylaxis for pneumocystis jirovecii. So azathioprine, it's a purine analog, and the dose is 2 to 3 milligram per kilogram. It is a slow-acting agent and becomes fully effective only by 6 to 12 months. And the efficacy is monitored by MCV. If MCV increase is less than 5, you may have to increase the dose by another 0.5 to 1 milligram per kilogram. And if it is still not attained, you may have to consider switching to another agent. For mycophenolate mofetil, the dose is 1 to 3 grams per day, given as 2 divided doses. It is again a slowly acting agent, but slightly earlier acting than azathioprine. The therapeutic target is lymphocyte count, absolute lymphocyte count, which should be maintained between 1000 and 1500. And if that target is not attained, the patient has to be more closely monitored and decide whether switching is necessary or not. Methotrexate is supported only by a few case series, and the dose of choice is 15-25 milligram per week. Now, of course, the side effects of azathioprine, in addition to cytopenias and infections, there is a risk of lymphoma, which is very low. It's not a very marked risk, but it comes after 5 to 10 years of use, and is a higher risk when you're using it in children. In mycophenolate, the additional things you need to worry about are hypertension and GI side effects and teratogenicity. Methotrexate, of course, there is a cumulative side effect as well as teratogenicity that has to be considered. And before azathioprine is used, TPMT mutation assay or enzyme activity assay has to be done. And the new one, which is NUDT15, is another enzyme which is required for the conversion of azathioprine to active agent, and the reduction or unfavorable phenotype of genotype of these particular enzymes can result in myelotoxicity related to azathioprine. The monitoring for both these agents are weekly blood counts LFTs for the first 1 month, monthly for the 6 months, and then twice a year it has to be monitored. Mitoxantrone, cyclophosphamide are mostly reserved for very severe conditions or when it is refractory to treatment. Mitoxantrone has gone out of favor because we have good agents for MS now, and there is a high risk of cardiac toxicity with recurrent use. Whereas cyclophosphamide, it is to be used when patient is as an escalation agent, as an acute therapy also, and also for maintenance therapy. So for escalation therapy, you can use it as an immunoablative course, which is given 50 milligram per kilogram for 4 days. This comes with a high risk of bone marrow suppression. Or it can be given as 500 to 1000 milligram per meter square for 1 year, monthly, followed by bi-monthly pulses. But again, the cumulative dose should not exceed the specified amount for the weight of the patient. It has the risk of hemorrhagic cystitis and bladder carcinoma, as well as GI side effects, bone marrow suppression, and reproductive side effects have to be monitored in the patient. So summarizing, the platform therapies in MS have very few side effects and can be used long term, whereas the oral medications, the higher activity oral medications such as S1P modulators and cladribine, and those for non-MS therapies require more rigorous monitoring. Thank you.
Thank you, Dr. Shruti. I think within a small time frame, it is difficult to, cover and encompass. So I think you've done a great job by summarizing the key elements which most of the treating neurologists and residents and fellows need to know. So thank you very much for this comprehensive coverage of the older DMTs which have slightly fallen out of use or have become lessened and transitioning to the newer ones. So I think we will take the discussion towards the end of the completion of the seminar. So I'll move on to the next talk, which is by Dr. Thomas Matthew. Dr. Thomas Matthew is professor and head of Department of Neurology and dean at the St. John's Medical College. He's also the director of the fellowship program of neuroimmunology at his institute, and has a special interest in the subject of autoimmune neurology. Dr. Thomas won't be able to give the talk live because of some important personal commitment. So he has recorded the talk, and we will play his talk, which covers biological agents, agents that are currently being frequently considered in patients with highly active MS, and even at the beginning of the disease or the early onset of disease, where we are now thinking of giving more effective therapy. So Asmita, if you can kindly play the recorded talk of Dr. Thomas.
A very good evening to all. I thank Dr. Rohit Bhatia and Dr. Netravati for inviting me to give this talk on biological therapies in immune disorders. And here we will be covering types, doses, adverse effects, and monitoring of commonly used biological therapies. Biological therapies include a broad spectrum of agents which we use either to deplete the cells, or we use it for changing the proteins, or can use for silencing the mRNAs, genes. But here we'll be predominantly focusing on the biological therapies we use in neurological immune disorders, and with a main discussion on monoclonal antibodies. So we have around 12 monoclonal antibodies which are marketed for neurological disorders. And if you take demyelinating disorders, we have natalizumab, we have alemtuzumab, we have B-cell depleting therapies like rituximab, ocrelizumab, ofatumumab, and oblictuximab. And of all the B-cell depleting therapies commonly used in our country is rituximab. So we'll be seeing a little more on rituximab towards the end of the session. And if you come to other demyelinating disorders like NMO spectrum disorders, we use rituximab, eculizumab, inebilizumab, and satralizumab. In our country, we don't have eculizumab, inebilizumab, satralizumab, so we commonly use again rituximab for treating NMO spectrum disorder. Of these drugs, the FDA-approved drugs for treating NMO spectrum disorder, especially the aquaporin positive NMO spectrum disorder, are eculizumab, which got approved in June 2019, inebilizumab, which got approved in June 2020, and satralizumab in August 2020, and we have ravulizumab, which is recently approved in March 2024. So if you see these drugs, like how they act, rituximab is an anti-CD20 agent, inebilizumab is an anti-CD19, eculizumab and ravulizumab acts by inhibiting the C5 complement, and tocilizumab and satralizumab acts as an anti-interleukin 6. So if you see the B-cell chain, it starts from the stem cell and ends in the plasma cell. The CD20 positive cells are from pre-B cell and memory B cell. And drugs like rituximab, ocrelizumab, ofatumumab, and oblictuximab act through the CD20 and deplete the middle B cell chain, while inebilizumab is an anti-CD19 agent. Its action, the CD19 are on the surface of pro-B cell up to plasma blast and plasma cell. So inebilizumab depletes the pro-B cell to the plasma cell, and that's how they affect. And the B cells are destroyed. There are no B cells for antigen presentation. The antibody production is impaired, and the B cell stimulation on T cells are impaired. So that's how it affects in immune dysfunction. It helps in the immune disorders by depleting the antibodies and reducing the antigen presentation and other mechanisms. So while interleukin-6 also has an important function, interleukin-6 helps in polarization of T cells, and it also results in T helper 17 induction. It also can stimulate the B cells and results in autoantibody generation. It also damages the blood-brain barrier, closing the leakage of blood-brain barrier. And also it can stimulate the complement cascade, and it can also cause astrocytic and oligodendrocyte damage. That's the mechanism by which interleukin-6 acts. And what are the therapies which we use employing to manipulate these interleukin-6 and B cells? As you know, we use agents like rituximab and other B cell therapies for manipulating the B cells, while you use satralizumab and tocilizumab are the ones which are used for manipulating interleukin-6. And among the demyelinating disorders, we have just touched MS and NMOSD, while MOG spectrum disorders, we still use rituximab. But a subgroup of patients do not respond to rituximab, and in this subgroup, we use tocilizumab, which is an interleukin-6 blocking agent. And then we use IV immunoglobulin, which is given as a pulse therapy. In acute attack, we give a course of 5 days, 0.4 gram per kg, and after that, you pulse every month, a half dose of it, like you give a 2 gram per kg for the initial treatment, and for maintenance, we give around 1 gram per kg, half the dose as maintenance every 4 weeks. And that's how we manage MOGAD, which are refractory to the first-line agents, especially rituximab. And now we go to other monoclonal antigens which are used in other disorders like myasthenia gravis, again, especially the MuSK-positive myasthenia, even acetylcholine receptor antibody-positive myasthenia, we give rituximab. And if we give early in the course of the disease, in early myasthenia gravis, the rituximab becomes effective. And other drugs which are come up in myasthenia gravis are again the complement inhibitors like eculizumab, which blocks the C5 and prevents the formation of C5b9 membrane attack complex. And we have eculizumab, which is a humanized monoclonal antibody targets against complement 5. We have a new addition, which is called the ravulizumab, which is again a humanized monoclonal antibody targeting C5 complement. And ravulizumab, the advantage is that its T1/2 is long. And while eculizumab has to be given every 2 weeks, ravulizumab can be given every 8 weeks. And that's the advantage of ravulizumab. There is another synthetic macrocyclic peptide inhibitor of terminal complement protein 5, which is called silucoplan. It is subcutaneous, and that's also a complement inhibitor, which is used in myasthenia gravis. There is another class of agents which are called the neonatal Fc receptor inhibitor. And neonatal Fc receptor plays a pivotal role in maintaining IgG homeostasis and IgG recycling. When an neonatal Fc receptor binds to an IgG, it protects the IgG from lysosomal degradation, and it prolongs the half-life of IgG, and that's how this Fc receptor inhibitor works. So this is a picture which shows how the neonatal Fc receptor, which is in a violet color, we can see the FcRn receptor. And when IgG are taken by the cell by endocytosis, when it binds to the FcRn receptor, it forms a complex, FcRn IgG complex. And when you form a complex like this IgG is salvaged and it doesn't go for degradation in the lysosomes. And they are recycled, and they exocytosis, it is produced back out of the cell. It goes to the interstitial area and to the circulation, it is put back. So binding of IgG to the FcRn receptor prevents its degradation, and its half-life is prolonged. But when you block this neonatal Fc receptor, these Fc receptors are not available for complexing with the IgG. So that IgG goes for degradation in the lysosome, so that there is the half-life of the IgG is shortened. So that's how these Fc neonatal receptors act. So Fc receptor inhibitors in rat models of myasthenia gravis have been used, and when these anti-FcRn antibodies are used, there was a lowering of the levels of anti-acetylcholine receptor IgG, and this led to the significant reduction in severity of the symptoms, and that's how this FADG mode was trialed, and it has got approved by FDA. And another interesting aspect of Fc receptor inhibitor is that only IgG is affected by the FcRn mediated blockage, while IgA, IgD, IgE, and IgM do not depend on FcRn related homeostasis. So very selective immune suppression. So a FADG mode was approved in 2021 for treatment of myasthenia gravis. And there is another one which is called rituximab, which has a similar mechanism of action, and is got approved in 2023. And also we have other disorders were used like autoimmune nodopathies due to neurofusion antibodies. They are IgG4 and they respond well to rituximab. And then a lot of other disorders were used, monoclonals like autoimmune encephalitis, you use rituximab, Fire syndrome, you use tocilizumab, stiff person syndrome. IgG4 related disorders responds well to rituximab, then other CNS vasculitis and autoimmune neuropathies, especially nodopathies. So coming to this table, and now we will be seeing tables because we don't have a long time is only 20 minutes, so we can't go through all the antibodies in detail. So I've summarized everything in tables. In the first few tables, we see the mechanism of action, and then we see the dosages and monitoring. So when you take natalizumab, which is an humanized IgG4, it blocks alpha-4 beta-1 integrin, and it inhibits the entry of lymphocytes into the brain parenchyma. It is used in RRMS. Rituximab, ofatumumab, ocrelizumab are all CD20 depleters. Rituximab is used in a broad spectrum of diseases: RIM, RRMS, NMOSD, myasthenia gravis, MuSK myasthenia, CIDP variants, autoimmune nodopathies, and anti-MAG neuropathies. While ofatumumab is used in RRMS, ocrelizumab is used in RRMS and is specifically approved for PPMS. While alirocumab is a CD52 depleter, and both T and B cells are depleted, it's used for RRMS. Inavolisumab is a CD19. It depletes B cells from the pre-B cells to the plasma cell. It is used for the treatment of aquaporin 4 positive NMOSD. Tocilizumab is an IL-6 receptor blockade and blocker, and it is used for NMOSD and MOGAD. And then we have satralizumab, which is an interleukin-6 receptor signaling blocker. It is used for aquaporin 4 positive NMOSD. Eculizumab, we have seen silucopan, you have seen they're all C5 inhibitors. Eculizumab is used for anti-acetylcholine receptor positive myasthenia gravis, aquaporin 4 positive NMOSD. Silucopan is used for myasthenia gravis, while a FARTG mode, which acts through the FcRn receptor and prevents the immunoglobulin recycling, is used for myasthenia gravis. Rosanolixizumab, which is again an FcRn receptor blocker, it's again used in myasthenia gravis. While rituximab, we give as an induction regimen. We'll see a little more about the induction dose, but usually 1 gram or 2 gram as induction and 500 to 1 gram as a maintenance. Infusion time is at least 6 hours, and in the first infusion, preferably a little more longer. You can take 8 hours, 10 hours, go slow. That is the first dose of rituximab. When you give rituximab, we have to be careful of the infusion reactions and the other side effects which come, recurrent urinary tract infections in a subgroup of patients. And then you can have infections with herpes and varicella, but rare, but we have to be careful. And we have to do pre-workup with hepatitis B, hepatitis C, HIV, and then hepatitis B core antibody. And if core antibody is positive, you have to give an antiviral agent 2 weeks prior to starting rituximab, like tenofovir. Then we have to be careful while the infusion when rituximab is given. And ocrelizumab has given us an injection of 300 milligram on day 1 and another 2 weeks after another 300 milligram. And then maintenance dose of ocrelizumab is 600 milligram every 6 months. Infusion time for ocrelizumab is at least 2.5 hours. And monitoring and side effects are fairly same with respect to ocrelizumab, though the neoplasms were a bit more in the ocrelizumab group when compared in the studies. Ofatumumab, which is given as 20 milligrams subcutaneous at day 1, day 7, and day 14. And then every monthly we give subcutaneous monitoring, and adverse effects are similar to rituximab. Ublituximab has given 150 milligram day 1, and day 14 it is for 50 milligram, and then onwards every 6 months for 50 milligram. And the time for infusion for ublituximab is 1.5 hours. Monitoring for B-cell therapies are pretty same, while natalizumab is given as an infusion of 1 hour, 300 milligram every 28 days. In natalizumab, we are scared of PML, so we have to do the JC virus antibody baseline. If antibody is positive, we have to be careful. MRI brain has to be given at least annually, and if it is more frequently, if JC virus antibody is positive. And then other drugs which we have to be, we should know the dosage. One is, alendisumab, which is given 12 milligram IV for 5 days in the first year. And in second year, we give 12 milligram IV for 3 days. Infusion time for alendisumab is 4 hours. And when you give alendisumab, always be careful of infusion reactions. And also, we have to be careful of the cardiovascular events which can happen during alendisumab. FDA has given a black box warning on stroke with alendisumab. When you give alendisumab, we have to be careful of autoimmune disorders, especially thyroid autoimmunity. So very common, 30 to 40% of people can develop thyroid dysfunction. And then other ITP can occur, and Goodpasture syndrome can occur. So because of this, you need complete blood counts monitoring monthly. Liver functions have to be monitored monthly. Renal functions have to be monitored monthly. Urine routine has to be done monthly, and thyroid function test has to be done every 3 months. And skin examination has to be done yearly for malignancies, skin malignancies. And so we have to be very careful with alendisumab, and we have to need meticulous monitoring with alendisumab. Eculizumab is given as 900 milligram per week for 4 weeks, and a maintenance of 1,200 milligram on week 5, and then every 2 weeks, 1,200 milligram. The main problem with eculizumab is being a complement inhibitor. There's a risk for meningococcal infections, and meningococcal vaccine has to be done 2 weeks prior to eculizumab. And vaccine will not give 100% foolproof, guarantee that you don't get meningococcal infection. So we have to be careful. There can be meningococcal infection even on vaccination. So we have to tell patients with any signs of meningitis, fever, neck stiffness, we have to be altered sensory. We have to be immediately there to start the treatment, other it can lead to mortality. So, and the other thing is the cost of eculizumab. 300 milligram of eculizumab cost almost 1 lakh rupees. So it's a huge cost. 1,200 milligram can cost anywhere between 3 to 4 lakhs. So we have to be careful. The patients may not be able to afford, and it's not available in our country. Silucopan is given subcutaneous. Again, being a complement inhibitor, you have to be careful of meningococcal infections, and not only in meningococcus, other capsulated organisms. Same with eculizumab, Streptococcus pneumoniae, Haemophilus influenza, gonococci. So these are all infections can occur with these complement therapies. Inebilizumab is given 300 milligram on day 1, 300 milligram on day 15, and maintenance of 300 milligram every 6 months. Infusion time is 90 minutes. Same like other B-cell therapy, monitoring and adverse effects. Tocilizumab is given at a dose of 4 to 8 milligram every 28 days. Infusion time is 1 hour. One important thing to be monitored with tocilizumab is the lipid profile, which has to be, because dyslipidemias can occur with tocilizumab. Other monitoring is the blood counts and the liver function test. Satralizumab is given 120 milligram subcutaneous on 0th week, starting, and every 2 weeks 120 milligram for 3 doses, 0, 2, and 4 weeks, and then maintenance of 120 milligram subcutaneous every 4 weeks. Monitoring and adverse effects are similar as tocilizumab, while efgartigimod is given 10 milligram kg for 4 weeks and titrated according to response after that. And the infusion time is 1 hour. You can have hypersensitivity infections as the serum IgG levels may be lowered. UTI can occur. So we have to be careful with these urinary tract infections with efgartigimod. And it can also interfere with other vaccines because IgG levels come down. While rasanoliximab is given according to the body weight, and also it is given as a subcutaneous injection per week till 6 weeks and redose according to the clinical response. So that's how in brief about efgartigimod and rasanoliximab. Ravulizumab is given again as injection based on the body weight. So if you are between 40 to 59, we give 1,200 milligram. If you are between 60 to 99 kg, you have to give 1,500 milligram. It has to be given every 8 weeks as an infusion, and the infusion time is from 1.5 to 2 hours. And the monitoring and adverse effects are same like ravulizumab because the mechanism of action is same. And few slides on rituximab. As you know, rituximab is the mainstay of treatment, main monoclonal antibody as Indian neurologists we use for various diseases, be it multiple sclerosis, be it NMOSD, be it MOGAD, be it myasthenia gravis. We use rituximab. And rituximab acts in 4 ways, while by cell-mediated cytotoxicity, when rituximab binds to CD19, the rituximab connects with the macrophages and natural killer cell using the Fc gamma receptor. And this Fc gamma receptors, it causes cell-mediated cytotoxicity on the B cell. And also it binds to the complement, and complement activation forms the membrane attack complex, which again perforates the B cell and destroys that. And also binding of rituximab on CD20 causes apoptosis and death of B cell, and this is the 4 mechanisms by which rituximab act. Rituximab has a faster onset of action, longer duration of action, so that results in less frequent infusions, especially patients are doing well and you're monitoring CD19-20. You may delay the rituximab infusion by a few months. And it's a very favorable side effect profile in that we have used rituximab for years. We know what other things happen with rituximab, unlike eculizumab or inebilizumab, which we have not used, and we don't know what other side effects can occur. So we have long-term usage and long-term experience with rituximab. When you give rituximab, 90% of the circulating B cells are killed within 3 days of the first infusion of rituximab. But clinically, the maximum effects comes by 3 months, according to the studies. So it improves over months, and maximum comes by 3 months. And rituximab also increases the Treg cells in a favorable way so that it can repair the immune dysfunction. So we have classified the rituximab dose into an induction dosage and maintenance dosage. Induction dosage is called high dose induction if you give 2 grams, that is 1 gram 2 weeks apart. We call induction a medium dose induction when you give 1 gram, and a low dose induction when it is 500 milligram. And we call a maintenance dose as a high dose maintenance if you give 2 grams every 6 months, that is 1 gram 2 weeks apart, and we'll give 1 gram. And you do use a medium dose maintenance that is 1 gram every 6 months. And the low dose maintenance is called 500 milligram in 6 months. And what we have seen that most of the patients may need only a high dose induction or a medium dose induction. For example, you're dealing with NMO spectrum disorder or a MOGAD. you may give a high dose injection 1 gram and 2 weeks 1 gram. While you are doing an MS, which has a mild attack, you need only 1 gram injection. And maintenance depends on the disease, and most patients need only, in Indian context, most diseases need only 500 milligram every 6 months. So we did a study in NMOSD for 40 patients in which we presented in Pactrums, and around 80% of people need only a low dose maintenance of 500 mg. And when you're on a low dose maintenance, advantage is that your risk of infections are much less. When you give, a few of our patients needed a medium dose maintenance at 1 gram every 6 months, especially the people who repopulate fast the B cells, especially the young patients, may need a maintenance of 1 gram every 6 months. Or you get a relapse on a 500 milligram of maintenance, then you need a high dose maintenance. High dose is very effective. Not high dose, the medium dose, the 1 gram every 6 months is effective. But what happens is that in this group, you get urinary infection, pneumonia. And in NMOSD group, we had 2 deaths in patients on maintenance dose of 1 gram every 6 months. So when you go higher dose of infection, you have a more B cell depletion, and then more profound B cell depletion, and then the infections risk goes up. So we have to balance the dose based on the disease, based on the severity of the disease, based on the relapses, based on the severity of the relapses, and the age of the patient, and then the comorbidities. We may have to balance the maintenance. So by and large, I would like to say that 1000 milligrams 2 weeks apart, or 1000 milligram may be a good induction, and a maintenance of low maintenance of 500 milligram every 6 months will suffice most patients. And then you may do 1000 milligram in those young people who are repopulators, fast food populators, or you get a relapse based on when you are on a low maintenance dose. And also we can decide on the disability and other factors may take in and go for a higher dose. For example, they are already in a progressive phase and a high dose. So maybe give a high dose to see that are they getting better. And some monitoring, the pre-dose monitoring, we have to follow the protocol with Rituximab. Oh, sorry for that. So baseline HIV, hepatitis B, HBsAg, hepatitis B core antibody total, and then hepatitis C. Because if core antibody is total, give antiviral treatment like tenofovir just 2 weeks prior to the Rituximab, and then continue the entire course of Rituximab. And even after stopping Rituximab, you may have to continue for a long period of 6 to 12 months after the Rituximab, the antiviral therapy. We use tenofovir, and especially tenofovir alfenamide. That's what we usually use. And then you can do the baseline CD19-20. So HIV, HBsAg, hepatitis B core, and hepatitis C. And then CD19-20 baseline to know if you want to monitor with the CD19, you should have a baseline CD19-20. And then pre-medicate with IV methylprednisolone, 100 milligram, 30 minutes prior to infusion. You can give an antihistamine and a paracetamol also prior to infusion. And then you give a slow infusion. So if some reaction happens, stop the infusion for some times and restart at a very slow infusion rate. This is a protocol which we follow in our place. We use a protocol of 1 drop per minute for 15 minutes. That will come to around 4 ml per hour. Then after 15 minutes, we make it 8 ml per hour. Then we make it 16 ml per hour. Then 32 ml per hour. Then 42 ml per hour every 15 minutes. And at 64 per ml hour, we just continue till it is over. It's a very slow infusion rate to prevent the reactions. So side effects, infusion reactions, and most of us know how to manage the infusion reactions. And then what we commonly see is UTI, especially patient is a SPMS patient with a lot of bladder symptoms. They are the one of people who are more prone to this UTI. And then viral infections can happen, like varicella herpes, very rare, especially young people, you don't get much of this infection. And beware of the COVID-19 infections. If you get, there's a chance that you get a more moderate to severe COVID, and a prolonged hospital stay and admissions can happen when you are on B-cell depleting therapies and you get COVID infection. So I'd like to conclude my talk by saying that biological therapies have revolutionized management of neurological diseases like MS, NMOSD, myasthenia gravis, MuSK-positive myasthenia, and autoimmune nodopathies. And though a lot of biologicals have come, in India, we have Rituximab, and with the availability of generic brands, we use it more because most of the people can afford Rituximab, and we know it is has a good efficacy and a very favorable side effect profile. We are telling there's no side effects, but a favorable side effect profile, and that makes us Rituximab best choice. And if somebody is resistant to rituximab, that is a very unusual scenario. But if somebody is resistant to rituximab, like you might have, then you have to see whether you have given the proper dose of rituximab, patients are compliant, and then if all this proper dosage and patients are compliant and they're truly resistant, they're like FC gamma receptor, gamma 3A receptor, phenotype FF or something like that, which makes you resistant to rituximab, then we may have to go to other biologicals like eculizumab or ravducimab, or you may go for inebilizumab or one of those newer drugs which are anyway not available in the country, and that may be the future. With that, I conclude, and I thank again the IAN autoimmune subsection, especially Dr. Rohit and Dr. Netra for inviting me to give this talk. And I also thank the team behind the scene for recording my talk and spending time doing all the background work. And I thank the team behind, and especially Bhavesh and others. And thank you.
So we thank Dr. Thomas for a very lucid and detailed description of the biologicals. I think each of the biological can take its own time to cover because each of them have their own, own indications, own monitoring. But I think comprehensive cover has been given. So we've heard about disease-modifying treatments from Shruti and also the biological agents from Dr. Thomas Matthew. And many times in clinic, we have a concern about how do we risk monitor our patients, especially on multiple immunomodulators. I think to cover this important topic, we invite Dr. Siddharth Jain, who's a colleague at All India Institute of Medical Sciences, New Delhi, in the Department of Internal Medicine, and he's got a special interest in rheumatological conditions and immune-mediated disorders. He's got many ongoing research projects, and he's also the associate editor of the International Journal of Rheumatic Disease and Indian Journal of Rheumatology. So I think without losing much time, I would rather listen to Siddharth and his important inputs for monitoring and advice regarding vaccinations. Off to you, Siddharth, for this.
Thank you, sir, for the kind introduction. Are my slides visible and am I audible?
Yes, yes.
Thank you, sir. So thank you for the introduction, and thank you and Netra ma'am and the autoimmune section of IAN for giving me this opportunity to discuss this very important topic, which is the checklist and the vaccination concerns which pertain to use of immune therapies. So as you can see, there are two parts to my title. One is the checklist part and the other part is the vaccination part. So as we have heard over the last two talks, so the checklist is essentially a structured list which compiles the adverse effects and the contraindication of the drugs that we are talking about, the conventionals as well as the biologics. We just put them out, draft them down in a protocolized manner, includes a history, includes an examination, includes some investigations like this, and we don't really need to go into details, but essentially centered around things like infections, specific things like pregnancy, malignancy, specific side effects like heart failures, demyelinating diseases, malignancies, GI bowel perforations for tocilizumab, etc., etc. So let me not spend a lot of time on this because we already have just 20 minutes. And let me move down to the major part of the topic, which is vaccination. And these are the subheads along which I would like to cover this topic. So let's assess the need, the efficacy, the safety from the point of view of both the immune-mediated disease as well as the unrelated aspects, the cost, how do we really time them with respect to the immune modulatory therapies, and some special scenarios. We have clearly discussed over the last 1 hour that immune-mediated therapies and neurologists go hand in hand. So irrespective of where the localization is, IMTs are here to stay. There are newer drugs being developed, the armamentarium is ever expanding. And in this background, infections are always lurking around. And we all know prevention is better than cure. As far as infection prevention is concerned, we all know about the essential principles. And we also know that vaccination forms the backbone of prevention as far as available vaccines for vaccine preventable infections are concerned. We know it all. And we know that these patients are at higher risk for acquiring infections. We also know that there is a chance of greater severity once the infection is acquired. But we are very wise. We also know that these responses to vaccination will be affected by the therapy. We are scared that the vaccination may precipitate the disease flare. Look at COVID vaccine, look at the side effects, and look at the phobia. And we also know that live vaccines are risky. And with this excessive knowledge, there is an element of uncertainty, and that is what ends up with most of us missing the bus. And this is not conjecture, my dear friends. This is proven by data. So there is a very low uptake of vaccine in adults. And if you see this graph, the green line represents MS. And this is not just true for MS, but talk about diseases which I take care of, the rheumatological diseases, talk about the GI autoimmune diseases. The vaccine uptake is low, less than 40%. Let's try to understand why. So since this is a neurology audience, let's spend some time on this topic. So as far as neuroimmunological diseases are concerned, the disease itself predisposes in a way to infection. So as we can see, there's a two-way correlation between infection and disease course. So the infection may alter the disease course itself may predispose to infection. The disease course is related to vaccination in a way as well. Both there's a bidirectional relationship. Then you add a third component to it, that is the disease-modifying therapies. They'll alter the disease course for sure, but they'll also modify the risk for infection. They will also modify significantly the responses to vaccination. And to complicate the story further, there are some unproven links, and where we know that infection might really cause neuroimmunological disease, vaccination might really cause neuroimmunological diseases. However, this has not really been proven, but there are some soft signals enough to make us wary. And to add to this recipe, we have some patient-specific aspects which might modify this: the age, sex, the comorbidities, the immunocompromised status, the immune functional status, social issues, how far, to what extent they can prevent themselves from infection, the co-medication effects, the complementary medicines, and the aspects related to vaccinations. What is the type of the vaccine? There are so many vaccines around the corner now. What is the additive being used? What is the preservative? What is the stabilizer? What is the adjuvant? Everything adds to the cocktail and adds a layer of complexity to our understanding. And my job over the next 15 or odd minutes would be to simplify this for you. So simplify this for the trainees, simplify this for the patient, simplify this for the neurologists. So I've divided my talk along these aspects. So these are the common queries that which any patient, or for that matter, any neurologist would encounter. So do I really need vaccines? Are they effective? Are they safe? I've heard they might precipitate my flare. What about my immune modulating therapies? Should I delay starting them? If they are already ongoing, should I continue? Should I stop? Or should I hold? If hold, for how long? When do I vaccinate myself? Early, delayed? Should I wait for my disease to go into remission? Should I wait for IMTs to be off? Which vaccines to give? Are they available? What is the cost? What about caregivers? So let's deal with all of these important points one by one. You'll not get these in as simplified. There are many guidelines all across neurology, across rheumatology, internal medicine, there are many guidelines. But what I am going to share is essentially a crystallized and a very simplified version that you can apply to your clinical practice. And if you can gain even 50% of what I'm trying to tell you, my job would be done. So let's deal with this one by one. So do I need vaccines? I think we've discussed enough. There's no alternative answer to this. Our patients definitely need vaccines. Are they effective? That's the first point. So there is enough data to suggest, not just in immune-mediated neurological diseases, but across rheumatological diseases as well, that vaccines in these immunosuppressed patients do work. They work. They might not work as much as they work in healthy controls, but they do work. And they are doing their job of preventing an infection. So yes, they are effective, no doubt about that. The only modifier here is the ongoing immunotherapy. So immunotherapy does alter vaccination response. What is the exact alteration? Nobody knows. The data is very sketchy, but we have enough reason to believe that the vaccination responses are altered, they are blunted. To what extent? Is there any inter-individual variability? We are not very sure, but the responses are blunted. To what extent they are blunted would again depend upon what is the type of drug being used, where is it acting along the immune axis, is it more along the innate, is it more along the adaptive, etc., etc. So that is enough for us to know as far as effectiveness is concerned. So these vaccines work. Now come to the next aspect. Are they safe? If you look at the side effects of vaccines, I think neurologists would encounter them more than anybody else. So talk about MS, talk about LGBS, talk about EDEM, and you would get numerous reports, numerous patients, and I received a vaccine, and this is what I've developed. So what is the take on that? Is it inducing disease? Is it worsening a pre-existing disease? And there has been synthesis of enough data to suggest, there are meta-analysis, there are in fact prospective trials as well, that there is no correlation of vaccine with induction of MS. As far as GBS is concerned, it does occur, but it's a rare event. It can happen with vaccination to a lot of vaccines like influenza, COVID, yellow fever, rabies. But what is important to note here is the third point. If you see the risk of GBS with vaccine, it is 1 per million. And if you put it head to head with the risk of GBS, which can happen with influenza, which will occur more likely than not if you don't take the vaccine, is 17 per million. So putting things in context, putting things in numbers is very, very important. So whilst these side effects may occur, they are not as frequent for us to alter our practice or for us to not offer these vaccines to our patients. There are numerous vaccine adverse effect reporting registries, and you would find n number of neurological diseases which have been reported with these vaccines. But the word of caution here is, how sure are we about causality? I would spend just a minute to tell you about the famous controversy that happened with the MMR vaccine. So as if you go late in the 1990s, early 90s, basically, Lancet published an article that MMR vaccine leads to autism. So that was based on a small case series, not very well reviewed, but the Lancet published it. And it led to a practice change. People stopped giving MMR vaccine and children started dying. So much so that people had to really look up the data, synthesize the data, and create a lot of public awareness that MMR vaccine is not related with autism. What you're seeing is a coincidence rather than causality. And that one poor publication led to 10-year delay of this being retracted. And that 10-year delay led to a lot of loss of lives. So attributing causality to vaccine adverse effects is very, very important, more so from the point of view of neurologists. Then let's come to the next important aspect. How do we really take care of the immune modulatory therapy? So as far as vaccination is concerned, when to give is essentially a multifactorial decision, which depends upon a lot of factors. What is the clinical situation of the patient? What is the type of vaccine? What is the type of disease-modifying therapy? How soon do we want protection from the infection? How comfortable are we with a poor response to vaccination? And what are the chances of the side effects? So if you talk about the clinical situation, it is a proven fact that a disease in remission will have a better vaccination response than a disease which is actively flaring. So general principle for all of you practicing, if there is a disease which is currently relapsing, hold on. Treat the relapse. Once the relapse is better, then give the vaccine. Very clear. Second point, type of vaccine. So we're all aware of the live vaccines and the killed vaccines, but the spectrum of vaccines has increased tremendously. So apart from live and killed, we have toxoid, we have conjugate vaccines, we have subunit vaccines, we have mRNA vaccines, we have virus-like particles, we have adenoviral vectors, we have bacterial vectors. So n number of vaccines. But as I said, if you look at data, we have more data on the traditional vaccines, which are the live and the killed one. And this is the table that I have demonstrated for that. So the live vaccines essentially are the intranasal influenza, MMR, varicella, rotavirus, yellow fever, and zoster. And the killed ones dominate. Why this is important to know is, as is very intuitive, so any vaccine which is live, so live vaccine has the organism which is live. So in an immunocompromised patient, it definitely can cause disease. So for us, for any patient on immunosuppression, we do not want to give live attenuated vaccines. So what is the alternative? So for those agents which have a killed vaccine alternative, you give the killed vaccine. So we have, for influenza, we have killed vaccines, you give the killed vaccine. For zoster, initially we were heavily reliant on Zostavax, which was a live vaccine, but now we have Shingrix, which is a killed vaccine. So you can safely give that. Don't give Zostavax. That is one alternative. Second is, if you do not have alternatives. So if you look at, say, varicella, you look at MMR, you look at yellow fever, where there is not an alternative, what do you do? So obviously, when there is ongoing immune therapy, you do not give it. If so, you do not give it, or you stop the vaccine or stop the ongoing treatment, then wait for its effects to go, then give the vaccine. then wait for some more time before the therapy can affect the vaccine, and then go on as usual. This is a table from Nature Reviews Neurology. I have highlighted this, looks very complicated. What I wish to emphasize from here are 2 points. One is the type of therapy makes a difference. So if you look at interferon, so it is considered more of an immunomodulatory therapy rather than an immunosuppressive therapy. So when we are dealing with immunomodulatory therapies, we're not very concerned with the risk of infection. So as you can see, there's a big 0 here, there's a big 0 here. So safely give an activated vaccine, safely give live vaccine. So whenever you're dealing with the decision about vaccination, look at your therapy. Is it immunomodulatory? Is it immunosuppressive? Immunomodulatory, don't need to think a lot. Immunosuppressive, you need to put your thoughts. So for the live vaccines, you will not give it if the therapy is ongoing, or you will hold it, stop it for some time, let its effect go away, and then give it. To simplify this, I will take the perspective from rheumatology because that's my comfort zone. So there are guidelines from the American College of Rheumatology as well. Much safe, much easier to interpret. So I will take that reliance for the purpose of this talk, because the purpose is for us to understand what we are really doing. So if you've not yet started therapy and you've given the vaccine, there's a default hold period of 4 weeks that is given. So aapne live vaccine diya, hold for 4 weeks, then give whatever therapy you're giving. If you ask me what is the evidence for just 4 weeks, there's no evidence. It is a ballpark figure, but this ballpark figure is estimated from the point of view of 2 things. So all of the drugs that we give, they have a sort of prolonged action. So to basically minimize the effect of the wear off, we basically want to stop it for a longer time. So this concept is more applicable if you are holding the drug before the vaccine. And as we can see, for the conventional drugs, 4 weeks is what is followed. But if you look at biologics, which are longer acting drugs, so the stopping period is basically defined by the dosing interval. So if you're giving Rituximab every 6 months, so why are we giving Rituximab every 6 months? Because we tend to feel that by 6 months, its effects is mostly wearing off. Although that's not true in all cases, as Dr. Thomas also said. But that's the ballpark figure. So one dosing interval is when basically the effect of that biologic is wearing off. So you utilize that. So when your next dose is basically essentially due, then some weeks before that, you give the live vaccine. So if we say it is Rituximab, you give it when the next Ritux is due, or maybe 2 weeks before that, then hold on for 4 weeks so that the vaccine efficacy is not affected. And then you go on as usual. After the vaccine, the hold period basically is to develop a good immunogenicity to the vaccine and to prevent the infection from arising from the live particle that is there in the vaccine. So this is as far as the live vaccines are concerned. They need to be given a lot of thought, but we need to not be scared of them that we don't give them at all. Then coming to the killed vaccines. So as far as killed vaccines are concerned, there is some evidence to suggest that you can safely give them because they do not have a live organism. So there is at least no risk of harm to the patient. The efficacy may be compromised because of the blunting of responses. So that's why we try to, develop strategies as to how we can increase the responses to vaccinations. One such strategy is holding on to the drug for some time, which has been proven in trials, especially for drugs like methotrexate. So it has been shown in well-designed RCTs that if you hold on to the dose of methotrexate for 2 weeks after the vaccination for influenza, then the responses to vaccination are much improved. As is very intuitive, this comes at a counterbalance that when you hold on to the medicine, there might be a disease flare. So whether you give that hold or not is an individualized decision based on what are the chances of my patient flaring and how strongly do I want more vaccine responses, better vaccine responses. So it's always a balance that I have to maintain, and it'll be an individualized decision whether I want to give that hold or not. So as far as methotrexate is concerned, the hold is proven as far as RCTs are concerned. For other vaccines, there is evidence for COVID-19 as well. But if you look at other non-live attenuated vaccines, the evidence is sketchy. So that's why the guidelines suggest you rather continue methotrexate because of paucity of data. As far as Rituximab is concerned, even Rituximab blunts the responses for influenza as well as pneumococcal. But since influenza is an annual vaccine and your asset is going to give it next year, so it is said that rather than withholding definitive therapy where it might be indicated, you might as well give Rituximab whenever you have to, and then you can always repeat the influenza vaccine next year. However, When the disease is well controlled and you can fiddle around with rituximab, we'll apply the same principle. So we would want to give the vaccine, say, around the next dose of rituximab about 2 weeks prior to that, so that we can get maximum responses. So as far as steroid dosing is concerned, so we often tend to, when we are talking about biologics, we somehow tend to we don't talk about steroids as much. If you talk about internal medicine, talk about rheumatology, talk about neurology, we don't talk about steroids as much. So steroids are the main culprit in a lot of cases. Hence, steroid dosing becomes an important factor. So when steroids are on low dose, we are fine. But when steroid dosing is above 20 milligrams in a day, we would want to defer even the killed vaccines, for the same reason that we want better vaccine responses. So when your steroids are tapered to less than 10 mg, less than 20 mg in a day, the lower the dose, the better the vaccine responses. Here, as you can see, influenza is still a give even with 20 mg prednisolone, but the rationale is the same. Influenza is an annual vaccine. Even if you get some blunted responses, we are fine. So any response is better than no response. Then the next part. So what vaccines finally? What is the cost? Are they really available or not? So as far as which vaccines are concerned, we need to understand that all adults, even general population, there are some vaccines which are required even for adults. Our traditional concept of vaccination being a pediatric phenomenon has been overhauled. So adults need vaccination. So, and these patients need vaccination as well. So all those routine vaccinations, plus those who are immunosuppressed, need vaccination for influenza, need vaccination for pneumococcal, need vaccination for zoster. It's very important for us to understand. And then, based on the specific clinical setting, based on the drug under consideration, there are some additional vaccines which we will talk about. So as far as influenza is concerned, there's no doubt. So all patients, so again, I have borrowed this from ECR, but is applicable across basically. So above 18 years, on immunosuppression, you give them. Above 65 years, even if they are not on immunosuppression, you give them. Ideally, you would want to give high-dose vaccine and adjuvanted vaccine. Why? So you're basically trying to circumvent the blunted vaccine responses that would happen in these patients. So that circumventing is done either through use of an adjuvant or through high-dose vaccine. This is what is recommended. These are American people. But if you talk about the Indian perspective, we do not have these high-dose or adjuvanted vaccines. So we are using the conventional ones, so which are Florix tetra, Influvac tetra, Vaxi-Grip, etc., etc. As we can see, I've jotted down the cost just for you to know that these can be safely given. They are given IM at a dose of 0.5 ml. As far as pneumococcal is concerned, again, less than 65 years, above 18 on immunosuppression, you give pneumococcal. The vaccine strategy is called as a prime boost strategy. So what do you mean by prime boost? That initially you give a conjugate vaccine. So in our country, we have PCV13 as of now. So that is what you give first. That is available by the name of Prevnar 13. But soon you will also have PCV15 and PCV20, which has been licensed in the US and will probably in a couple of years be licensed in India as well. So once you have 15, you would obviously move from 13 to 15. And if you have 20, then that alone suffices. But if you're using PCV13 or PCV15, you need a boost. So after 8 weeks, you give a pneumococcal polysaccharide dose of after 8 weeks. So this is what is a prime boost strategy, would be relevant for patients on immunosuppression. As I said, these are the various forms of vaccines which are available with the costing. PCV15-20 not yet available in India, but will soon be. Coming to zoster, so very hot topic these days. So all patients above 18 need to be vaccinated for zoster, and the general public, even if they are not immunosuppressed, above 50 have to be vaccinated. The vaccination has been revolutionized with the licensing of Shingrix in India, which was as of end of 2022. So that has made our life easy. Shingrix is a recombinant vaccine. Zostavax was live, so we had difficulty giving it in immunocompromised patients, and its immunity also used to wane. However, with Shingrix, all of these effects are gone. There's no risk for vaccine-induced zoster, and we can safely give it. The minimum interval between the two doses is 2 months, but so we will obviously be choosing lesser intervals where the risk for activation of zoster is high, and where the risk of the activation of zoster is low, then we can maybe stretch the spacing interval. Again, the concept of individualization. Then coming down to, as Dr. Thomas said, so no matter how many biologics come into the picture, currently the dominant one is rituximab. And with rituximab, hepatitis B is very, very important. So I really love the fact that Dr. Thomas talked about the anti-HB core antibodies, which I think needs greater sensitization. So all of us are doing hepatitis B surface antigen, but anti-HB core antibodies is not somebody that everybody is doing all across. So we have to do anti-HB core antigen. And as the flow chart, so these are guidelines basically from the AASLD and the NASL. So if the HBsAg is positive, so basically we have to look at the HBV DNA levels. They are above 1,000. This meets the criteria for treatment. So we'll treat the chronic Hep B. However, if the treatment indication for chronic Hep B is not met, we need to reassess the risk for reactivation of Hep B with the biologic we are considering. So the risk of reactivation of Hep B varies as per the biologic in consideration. And if you look at Rituximab, it falls under a high risk for reactivation in both HBsAg positive patients as well as those who are negative but positive for anti-HB core. Thus, they need to be started on HBV prophylaxis, as Dr. Thomas said, and this would continue at least till 6 months after the end of B-cell depleting therapy. So this is what the algorithm that has been devised by NASL. So with HBsAg positivity, you do the HBV workup and essentially give the preemptive treatment, which will continue for some long with periodic monitoring. So is the treatment for anti-HB core antibodies. There's some difference in NASL, which says that if the biologic is planned for short term, rather than giving prophylaxis, you just monitor closely. But all of our patients relatively receive biologic for long term. So we are looking at preemptive antiviral therapy for a longer term. So the hepatitis B vaccines are available either as single antigen. So we have Recombivax HB, we have Engerix B. And sometimes when these are not available, hepatitis B is also available in combination vaccines as Twinrix with hepatitis A or as Pentavax with the DPT and HIP. So there is, although Eculizumab is, so these are now some special scenarios I'll discuss briefly before concluding, that meningococcal vaccine will become very relevant when complement inhibitors become central. When Eculizumab patent gets over, cost gets reduced, availability gets normalized, then meningococcal vaccine will become very, very important. From your perspective and from our immunological, rheumatological perspective, there are other indications as well. So there are two vaccines. There's Menatra, there's Menvio, with varying conjugate levels, with varying vaccine interactions. As Dr. Thomas also briefly touched, so when we have risk of encapsulated organisms with complement therapies, we'd also want to give vaccine for Haemophilus B, which is available as single-dose biohip or maybe available as combination vaccines. Finally, the last bit about HPV from the rheumatological circles, age 26 to 45 does become an indication for Hep B catch-up, human papilloma virus catch-up. And I would, not taking more time, want to conclude that all our patients with neurological diseases will require vaccination. They need to be vaccinated early, preferably before initiation of immunotherapy wherever possible. If not possible, you have to give appropriate intervals between the vaccination and treatment, which will depend upon the type of vaccine. You would want to look at inactivator alternatives wherever possible. The type of immunomodulatory therapy, is it immunomodulatory, is it immunosuppressive, what is the dose? Whether you want to continue the therapy or interrupt it by giving a holding time will depend upon the balance between the risk of disease flare on discontinuation, vis-a-vis the vaccine responses which we want to upgrade, we want to avoid during relapses of MS, during exacerbation of MS. And the garden principle of some protection is better than no protection at all. We can always recommend some protection by using higher doses, adjuvanted vaccines or boosters. This is my final slide. As far as vaccination is concerned, this is a perfect example of one size not fitting all. We need to give our patients personalized vaccination plans. And I would like to conclude. And because 20 minutes was too less, I have jotted down some resources for further reading. There are guidelines for MS, which all of you would be aware of. But apart from these, there are very useful guidelines from our rheumatology circles, from CDC, from the American Academy of Pediatrics. The Association of Physicians of India has also come up with guidelines this year. So this would be worthwhile reading. Thank you so much.
Thank you very much, Siddharth. I think it was an excellent overview of vaccination. I think most of the concerns that we have in practice, you have touched upon, and I think within the limited time, I think the coverage of the whole, of the multidimensional aspects of vaccination were outstanding. So thank you very much for this talk, and we hope we will have questions towards the end, and we will take up those questions after Dr. Salil's talk. I think after these three wonderful talks, I move on to a very important point in the decision making is switching treatments for patients. And I think that's where most of us have to use all kind of thinking to make a decision of when to change and if to change and what should change. And with that, I invite Dr. Salil, whom I've known for many years as a colleague, and he's an excellent speaker. And currently, Salil is in Bahrain, and he was with us at AIMS, and then he has been in many army institutions teaching students and has been ardently working in the field of demyelinating disorders. So Salil will take us to his thoughts about switching or transitioning from one immunotherapy to another. So Salil, please.
Thank you, sir. Thank you, Dr. Rohit, sir. So I will be moving on to transitioning from one immunotherapy to another in multiple sclerosis. I'll be touching upon a few points about some few practical aspects of this transition. We know that the drug therapies which are available can also be looked at as low efficacy therapies, moderate efficacy therapies, and high efficacy therapies. Low efficacy therapies are the interferons, glatiramer, teriflunomide. Moderate efficacy therapies are the fingolimod, dimethyl fumarate, and high efficacy therapies are mainly the monoclonal antibodies. And stem cell therapy is used in certain situations. So reasons for switching can be multiple, but evidence has shown us that the most important reason for switching is lack of efficacy. And it's said that 55 to 60% of patients will need to switch their therapy within 3 years after starting their therapy. And this is multiple studies have shown similar findings over the last few years. So knowing something about switching, especially about the especially since at the current situation where we have many drugs available, it's important to know something about how to go about switching the therapy. So let's start with the first case. These are all hypothetical cases, but they've been made in such a way that these are common cases which each one of you will identify with. This is a 27-year-old female who was diagnosed as RRMS based on 2 clinical relapses and MRI features of dissemination in time and space. So she was started on the drug therapy, and after starting dimethyl fumarate, she has been very compliant with the drug. She's on regular follow-up and is clinically stable and tolerating the DMF very well. She's back to her normal life, so everything is fine. Now, at 2 years on with you, when she comes to you on regular follow-up, the MRI now shows 4 new T2 weighted lesions in the brain. She's otherwise stable. She has no problems. So what should we do? So this brings us to how should we go about monitoring disease activity. I'll touch upon this briefly before we go ahead. This is an important aspect about following patients, which will help us make a decision about change, whether to change or not. And the second is how to change and into what to change. So there's no consensus on what is the ideal method of monitoring patients. Most experts agree that patients should be followed periodically. Periodic could be as 3 months, 6 months, some say 12 months. Again, depends on the kind of patient which you have after starting a DMT. And the monitoring should be for relapses, for new T2 lesions, or new MRI lesions. It should be also for progression of disability. This is an important point that the new MRI lesions may appear initially after starting the drug therapy. And therefore, on follow-up, after starting the drug therapy, a rebaselining MRI, that means a second MRI, which should be a baseline, should be done and which should be used for further following up, and which, based on which one should make a therapeutic decision, whether to switch or not to switch. So when to consider switching, again, the lack of consensus of what is treatment goal and what is failure. So a spectrum can range from a single relapse of mild severity. I will tell you in a little while what do we mean by mild severity, or a single new MRI lesion within 6 months of starting DMT is concerning, but is usually insufficient to demand a change in therapy. However, any serious MS relapse, like multiple relapses, regardless of severity, or pronounced increase in MRI activity with multiple new T2 lesions, particularly after more than 6 months on therapy, should prompt a review of treatment options with a predisposition to change their DMT. So basically, anybody who you feel has got a significant jump in disease activity despite being on the therapy is what basically it means, the one which we should consider for therapy change. So how do I know that there is a jump in activity? So there are various methods again of noting it down. One is to try and achieve the idealistic goals of NEDA, that is no evidence of disease activity. Disease activity scores are there, which is RIO and modified RIO score. And recently the Canadian guidelines have come up with something called as minimal evidence of disease activity, a term which still needs a clear definition. Again, we'll see this in a little while. What does it mean? So NEDA is an ideal goal which has been the stated goal for all therapies. However, almost no therapy can achieve NEDA. NEDA is there is no evidence of any activity, which the activity should include clinical relapses. It should include that there is no evidence of disease progression, or there is no evidence of MRI activity. So once we the graph on the right shows the proportion of patients who started off. This is various registries. The names of the registries are given here. It shows the proportion of patients who started off with a high NEDA initially, but with a passage of time, say the first year, second year, third year, the proportion of patients who were maintained on NEDA came down. So as one can see, NEDA is an extremely difficult goal to maintain, whichever form of therapy which the patient may be on. RIO score is evaluated at 1 year after starting DMT. So 1 point is for more than 2 active lesions on MRI. Remember, our hypothetical patient had 4 MRI lesions, which we have detected. 1 point for relapse in the first year and 1 point for EDSS progression at the end of 6 months. So RIO score says that more than equal to 2 points predicted a poor outcome at 3 years. Our patient had had 4 lesions, which gave it 1 point, but less than 2 points. So we're not sure about whether there is poor outcome based on this score or not. Let's see the next score. So that is modified RIO score, which is based more on relapses actually. It gave 1 point for 5 or more new T2 lesions on MRI, 1 point for 1 relapse, and 2 points for 2 or more new relapses at the end of 1 year. So if the patient scored 2 or more points, the disability progression at 3 years was 65%, and 1 point was 33%, and 0 point was 24%. So our patient is somewhere between 24 and 33%. But is that enough? Should I change this therapy for our patient who is otherwise stable, but we have found 4 new T2 lesions? So again, let's see what a newer guideline says. Again, this is not idealistic, but they have tried to address each one of these issues in the newer guideline. So they've focused on their previous guideline was 2013. They've modified the guidelines more recently in 2020. This is the Canadian guidelines, and they have tried to focus on these kind of issues where they can try and address some minimal disease activity which is acceptable, that is why they call it MEDA, and beyond which they say that it should be a prompt for us to change the therapy. So they say areas of concern. So first is the relapse rate. So there are minor areas of concern and major areas of concern. So 1 relapse in the first 2 years is a minor area of concern. That means it's an acceptable. Major relapse is more than 2 relapses in the first year of treatment. If the relapse is mild or it is severe, defined by the functional impairment, recovery from relapse, that is the disability progression, if it is less than 1 point at 6 months, or it is partial relapse, partial recovery with 1 point at the end, progression at 1 point at the end of 6 months, will give you a major concern. And presence of 1 single MRI lesion is minor concern, and 3 or more lesions is major concern. So Again, they focus on rebaselining after this on follow-up. That means the initial baseline MRI is not what we should take. It should be the follow-up MRI, which should be the MRI which we should focus on follow-up. Indication for change in the initial 2 to 3 years is if there are more than 2 areas of minor concern, the ones which I have just shown over here, and more than one area of major concern. So let's go back to our patient. So our patient was otherwise stable. She had no relapse. These 3 points are gone. So only she had MRI evidence of activity, which was 4 lesions. So she had one area of major concern, which is an indication for change in therapy. But you may also find in our, say, supposing instead of 4 lesions, she had, say, maybe 2 lesions. Would it be an area for us to, would it be a prompt for us to change the therapy? Well, these are the concerns which we have no answer for, but it depends a lot on the interaction with the patient's desires, and the follow-up, which will probably help you and in change of therapy. So coming to the next case scenario. So this is a 36-year-old female, again, a common situation which we may face. This is a 36-year-old female who was diagnosed with RRMS and many years ago, or about, and she had a low disease activity on MRI. She does not have an insurance and stays in rural setting. After discussing treatment options available, she opted for weekly interferon beta 1a. She started Avonex, which was a weekly injection, and she tolerated that very well. She had no further relapses, and on regular follow-up with you on MRI, there has been no disease evidence of disease activity. But the problem is that although she's tolerating the drug well, she has heard of an oral generics which are available now in India. These generic options are much cheaper than the drug which she's using right now. And she's come to discuss this option of changing the drug therapy with you. So the reason for change in drug therapy, other than lack of efficacy of the drug, can be multiple. It can focus on drug related factors like cost, like the hypothetical patient who we discussed. It could be convenience of taking an oral therapy versus taking an injection, safety, tolerability, and so on. Patient-centered, that means likelihood of adherence, that supposing the patient is traveling and would prefer to take oral rather than the problems of carrying an injectable around, or has pregnancy plans, has other medical comorbidities, or it could be provider-centric, drug availability. Certain organizations where the person is working and is covered with insurance may provide only a certain type of drugs, or infusion capability. There could be several factors which could change the reason for the person to change here. So again, here it would depend on, and our job would be to try and explain that it would be ideal if you were to continue with this, but if you cannot, and cost is a factor and we do need to change, maybe we can consider changing and give the pros and cons of changing and the recurrence of disease activity on change to another DMT. The third scenario. Now, this is a 32-year-old male who was diagnosed as RRMS and started on fingolimod. In little more than a year, he has had 3 relapses, and the MRI shows significant increased activity. So a disease which is highly active despite starting on a moderate efficacy therapy, and the person has come to you, and now we need to take a decision. Which drug should I choose? Can I start the new drug immediately, or is there a washout period? How long should I wait before I start the therapy? And which drug would be a good drug to bring to control this patient's disease? So switching to a different DMT, unfortunately, there is no standard protocols available as of yet. The broad guideline principles include balancing the risks posed by the disease activity with the side effects of the new drug. Medication compliance and route of administration, this is the patient's desires, and shared decision-making considering benefits, risks, costs, and convenience, like any other form of therapy. This slide is the same one which I had shown in the beginning of the talk. We have high efficacy therapies, intermediate efficacy therapy, and low efficacy therapies. Low efficacy therapies are the interferons, glatiramer and teriflunomide. Intermediate efficacy is fingolimod, dimethyl fumarate, and the high efficacy therapies are generally the monoclonal antibodies, which are given as an infusion, except for ofatumumab, which is given as a subcutaneous injection, and cladarabine, which is given orally. Keep this in mind when we discuss the next slide. So when we feel that there is a progression in disease activity, as the arrow shows an upward, we need to move up the ladder. And maybe if we have started at a lower efficacy, we move up to a moderate efficacy or a moderate efficacy to high efficacy therapy to try and control the disease immediately. So this would be the choice which would dictate to us. So maybe we can offer to this patient natalizumab or anti-CD antibody therapy, maybe an ofatumumab, or if cost is an issue, maybe we can go for rituximab, which is also a very good option. So there are risks during the switch period. Now we have decided that we need to switch the drug. Now we need to discuss when should I start the drug. So a short washout time between the two DMTs increases the risk of severe immunosuppression and infections. This we should keep in mind and balance this against a long washout time, which increases the risk of rebound activity, relapses, disability, worsening, and MR activity. This is especially true for patients who are on fingolimod and natalizumab, because these are the drugs which when the lymphocytes are sequestered in the lymph nodes. So this guideline, that is the French guideline, published very recently, about 2-3 years ago, guides us about how to decide about the duration of the washout period. The earlier guidelines used to tell us about which one can choose, and used to mainly focus on the initial choice of drugs. But now, as more and more evidence is coming in addition to choice of the initial drugs, the more recent guidelines, that is the French guideline, and to a certain extent the Canadian guidelines, tell us about the washout period and how to start the drug so that we can mitigate the risk of the infection versus the rebound activity. So the green, the one you can see in green is if we decide to start the first line therapy, and the one in blue is if we decide to start the moderate or the highly efficacious therapy. So if the patient is on the first line therapy or the platform therapies, which includes interferon, glatiramer, teriflunomide, and dimethyl fumarate, there is no washout period, and the patient can start straight away, whether you're shifting over to another first line therapy or shifting over to a higher efficacious therapy. The patient can straight away move to the higher efficacy therapy, whichever one has identified. But keep in mind, if the patient is on dimethyl fumarate, one must monitor with lymphocyte count and ensure that the lymphocyte count is more than 800. And this is also true for fingolimod. If the patient is on fingolimod, like our patient was, and we decide that to switch him to a first-line therapy, then there is no washout period. But like in this case, because we need to move up to a higher efficacious therapy, and we decide, say for example, we decide in this patient that we need to switch over to natalizumab or rituximab, there needs to be a washout period for 1 month before we switch to this therapy. Natalizumab also, the washout period is 1 month, because if we wait too long, then the rebound activity is very severe and it can mimic iris, as we'll see a little later. Ocrelizumab, in case we do have patients on ocrelizumab, which is an expensive therapy, the washout period can be as long as 3 months. Mitoxantrone, for the rare patient who is presently on mitoxantrone, although we had many patients earlier on mitoxantrone, the washout period can be for 3 months if we are switching the patient back to a first-line therapy. But if we are going to another first-line therapy like an anti-CD20, then we need to wait for a 6-month period. Cladarabine, because it's an intermediate, and alemtuzumab, both these therapies, because they are intermediate therapy, we need to assess the patient periodically to see any return of disease activity before either giving them a repeat course or switching over to another form of therapy. So this is an important graph which can be easily got from the net, and it's available free online. And in case you do need to refer to it, you can easily get it from the internet. Now coming to baseline tests while transitioning. So the Canadian guidelines recommend that all patients who we are planning to transit must have routine blood tests, including specifically lymphocyte count, hepatic enzymes, pregnancy tests, vaccination tests, as was, we had an excellent talk by Dr. Sadat, and we heard about the vaccination status. And in case of dimethyl fumarate, as I mentioned earlier, we must look at the absolute lymphocyte count of more than 800. And teriflunomide, as Dr. Shruti had told us in the beginning, in the first talk, needs an active elimination protocol, especially if the patient is considering pregnancy. We prefer not to put the patient on teriflunomide beforehand. Let me say that we prefer not to put the patient on teriflunomide, especially if a female is planning pregnancy or is in that age group, because of this reason. So the other test, other thing which we have to be vigilant about is PML, and it is recommended that switching from a DMT with known risk for PML, like a dimethyl fumarate, although rare, it is a known risk. Fingolimod, natalizumab, and ocrelizumab, we should be vigilant. And lumbar puncture also, in addition to an MRI and a clinical status, lumbar puncture, especially for the PCR, may be indicated while monitoring these patients for any PML risk when we transit. If the patient was on first-line therapy, say patient was on interferon or glatiramer acetate, and then we need to switch over to a higher efficacy therapy, which could be natalizumab or fingolimod, and lateral shift to another interferon therapy does not really clearly offer any advantage. If the patient is already on moderate efficacy therapy, like our patient who we have just discussed, he's on fingolimod, then we can switch over to a higher efficacy therapy, which is anti-CD20 monoclonals or cladirep. Let's discuss another case scenario. This is a 34-year-old female. Again, a common scenario which you would be many of you would be seeing this case scenarios. This is a 34-year-old female who was started on natalizumab upfront for RRMS and because of high disease activity. As you would be aware and was told, was mentioned in the previous two talks on the drug therapy, there are many patients who we prefer to start on highly active drug therapies right from beginning because of their disease activity, and it's not necessary for us to move up the ladder. So this patient was given highly active therapy, natalizumab, right upfront. She received 20 doses. That is over. We all know that it's over 20 months, once a month dose, and her disease activity is under control clinically, and there are no relapses. All her MRIs have shown under good control, but her recent MRI has shown one T2 lesion. If you remember, a single T2 lesion could be an iffy, somewhere in between, that it could be a minor cause of concern, and even in the other scoring systems, it shows a lower concern. So it is, although disease activity is minimal, but her JC virus antibody is positive, and the index is 0.9, greater than 0.9. So this tells us that this patient is at increased risk for PML, and now we need to be discuss with her about shifting drug therapy, because she has been only controlled with a highly active drug therapy. Although some would like to give it up to 24 months, one can consider it, but only after discussion, because the risks go up, and there is a ready reckoner as far as the risks go available on the internet, which I would urge all the residents to take it and keep it with you in case you have such patients on follow-up. So in such situations, what should I do? So coming now to switch from natalizumab. So switch from natalizumab may be needed due to a high risk of PML. Like I mentioned, more than 18 to 24 months of therapy and a positive JC virus and an index of more than 0.9. So one way to mitigate the risk is use extended interval therapies. That means instead of giving every 4 weekly, now we give it every 6 to 8 weekly. Although it reduces the risk somewhat, but as evidence has shown, it does not totally remove the risk of PML. Now, during the washout period, we know that there is a definite risk for rebound activity, which can be as severe as immune reconstitution inflammatory syndrome, leading to permanent disability. So we have to watch out that we should not give the washout period for too long. So as I had mentioned earlier, the French guidelines recommend that the washout period can be for about 1 month. Some people say for 6 weeks, but so if you go by the French guidelines, it should be for about a month. And the drug which we can switch over to could be for any other CD20 drugs like ocrelizumab, ofatumumab, or rituximab, and can be considered and started early to avoid rebound activity. Now, during this period, after switching over, careful evaluation for subclinical PML, which may get further aggravated, is necessary. And this should be done by frequent clinical evaluation, MRIs, and JC virus titers, and maybe a CSF JC virus PCR also may be necessary. So to watch for PML, which is there. Now, switching from other highly efficacious DMTs, in case we have patients on ocrelizumab, ofatumumab, rituximab, or ublituximab, which we need to switch over the therapy, then in that case, we need to switch over to a different highly efficacious therapy, and we can do a lateral shift here in this case. Other anti-CD20 DMTs may lower JC virus antibody titers, and some experts, again, this is an important point, some experts check JC virus antibody titer before starting anti-CD20 DMT. This is during the switch process. Supposing a patient has responded poorly to 2 DMTs and continues to relapse, then alemtuzumab can be an option. The reason why alemtuzumab has been kept in the algorithm is that it is, as was beautifully brought out by Dr. Thomas, that it is highly prone to, the patient is highly prone to side effects. Stem cell transplant can also be an option in refractory disease. Now, coming to a fifth case scenario, and this is not truly dealing with a switch, really. Now, this 29-year-old female is a case of RRMS on dimethyl fumarate with good control of disease activity. She wants to plan pregnancy and has come to discuss the same. So what should we do? Should we ask the patient to stop the drug? Should we ask the patient to continue? Should we change over to something else, switch over to something else? So now here too, there is, so I have just summarized everything in a couple of slides. Pregnancy and MS is a topic by itself, and it can take a good at least half an hour, 1 hour of discussion on this. But just to summarize it, there are varied approaches on this, and some MS clinicians would prefer stopping the DMT upfront, and their argument is that only limited evidence is available concerning their safety during pregnancy. The second argument is that the MS relapse rate is much reduced in pregnancy regardless. And the third argument is that the DMTs can be started or restarted in the immediate postpartum period. This is versus the other group, which is more, has got a more probably a cavalier attitude and would like to continue their drugs straight away. And the decision must, their argument is that the decision must weigh the uncertain risks to the fetus posed by the DMTs for MS against clear benefits to the mother. So somewhere in between these two extreme approaches will be probably our decision making. But remember that the available data does not support aborting pregnancy because of the concerns regarding DMT exposure, even with exposure to DMTs with highest theoretical risks. So this is an important point again to remember. So these are three a part of the same table which I have split. To remember that during pregnancy, glatiramer acetate is the safest. Interferons are also recommended, and they do not, in case we feel that there is disease activity and the patient has got some disease, we can continue with that. The drugs which are not recommended and should be discontinued includes cladirabine and fingolimod. Dimethyl fumarate, there's no washout period, but it is there is no clear safety data available, although there is no human evidence of petotoxicity, but it's recommended that once pregnancy is confirmed, it should be stopped. And same with all the monoclonal antibodies. Again, for natalizumab, there is no washout period before the pregnancy is planned, although for the others there is. So natalizumab can be continued till the pregnancy is confirmed. So clear-cut teratogenic effects or high risk of teratogenicity is in teriflunomide, mitoxantrone. They should be discontinued or switched, and fingolimod. Coming now to the next type of patients who we may consider a switch is those who have got a progressive disease. Now here, unclear if highly efficacious therapies should be discontinued or continued after transitioning to SPMS. Now, most experts prefer to continue it, although evidence does not support it. Now, Canadian guidelines of 2020 recommend continuing the existing drugs or even escalating in patients with active disease despite transitioning to a progressive disease. Even in stable disease, there is no relapse, no active lesions. It is advised to continue the DMTs and consider discontinuation only after 2 to 5 years. So this is about progressive disease. Lastly, about de-escalation from highly active therapy. Should we plan to switch to a lower form of therapy or discontinue the drug? So this may be considered in patients on DMTs for more than 5 years and no evidence of activity for 5 years. Close monitoring during the de-escalation with frequent MRIs 3 to 6 monthly may be needed. But one must be aware of the very recent study published in Lancet Neurology, the DISCOM study, which showed that those in whom the drug therapy was discontinued, there was a 7.5 absolute risk between the ones against those ones in whom the drug was continued for new MRI lesions at 2 years in patients of 55 years of age and who had stable disease. So this must be kept in mind and discussed when discussing the need to de-escalate or stopping the therapy in patients who have got stable disease. So future areas which may help guide therapy, change in therapy include progressive brain atrophy, which possibly may be the part of the fourth part of NEDA, cognitive decline and biomarkers like CSF neurofilament levels. So to conclude, more than half the patients may need a switch in DMT, usually due to lack of efficacy. While switching for disease activity, a higher efficacy therapy is preferred, balancing risks versus benefit. A washout period may be necessary, but should not be too long to balance the risk of rebound disease versus severe immunosuppression. And pregnancy planning may need stoppage, continuation, or rarely switch depending on disease activity. Thank you.
Thank you, Salil, for covering it so well, and I think enumerating it under different clinical scenarios helps you understand the decision making much better. And I think there has been a comprehensive cover for switching. I know the time is small and there could be each element that could be discussed at length, but I think it gives a pretty much a bird's eye view for most of the usual scenarios that we face in our clinical practice. So I will now request Siddharth is there, Salil is there, Shruti, you can just be with us. We will spend the next maybe 5-10 minutes, slightly over schedule. So we have some questions, and I think the questions are general, and everyone is free to welcome. I mean, everyone is welcome to just give their opinion. So there was one question, Shruti, which I'll put to you because you've covered DMTs, and I think Salil can also take it up. Is about treatment choice with deranged LFTs on DMF. So I mean, in practice, someone who on follow-up comes with a report and we find that there is a transaminitis. What is the practical perspective of and pragmatic that we would commonly do in the clinic? You know, let's say someone who has been just started and you're following up the patient now with weekly, bi-weekly testing, and now they come up with a report which is slightly out. So any opinions for that?
Thank you for the question, and it's wonderful lectures today. Thank you, all the speakers. The elevation of transaminases, if it is less than 5 times upper limit of normal, we can actually continue with the medication, or we can slightly reduce the dose of dimethyl fumarate. Even 120 milligram twice a day is an effective dose. But if it is continuing to be significantly elevated, I would stop the medicine, at least transiently, see whether the level comes down or not. And if not, also evaluate for other etiology like hepatitis or non-alcoholic fatty liver or similar issues. If it is due to drug-induced liver injury, we expect the liver function test to normalize within a few weeks of stopping the medicine. So if that does not occur, it requires further evaluation. Unfortunately, all of the medicines have the risk of having a hepatic dysfunction, but it is class specific. It is not that one medicine will predispose to the similar side effect due to another medicine. So it is, if the person is repeatedly showing abnormalities on re-exposure to the same medicine, it is better to switch on to any other therapy. That is, there is no, the Rituximab possibly has reportedly the risk of acute severe liver failure. But other than that, interferons Glatiramer are safe medicines. There are a few patients with interferon who can show hepatitis function, and most of the newer agents can be tried once uh, the causes of hepatitis is ruled out. I'd like. Is there any other point to be there?
So,
Salil, yeah.
no, so I would probably agree with Dr. Shruti's approach. So I would probably do it this way, that better to err on the side of caution rather than regret later and cause side liver-related injury due to the drug which you're giving. So I would probably do the same. Anything above 3 to 5 times, I would in fact probably go ahead and stop the drug and see if it reverses with that. If it is that, then I would probably tell them that we need to switch the drug and opt for something else, some other drug which is there. It's also possible that one class of drug may cause a liver-related injury and the other drug may not cause. And these things, we can discuss it out with the patient depending on the disease activity and the concerns which the patient has shown.
Yeah, I think thank you, Salil and Shruti. I think that's pragmatic approach, that we look at what the elevation is. If it's a very mild elevation, we just follow it to the next week and see if it is rising. And if it is risen, as you said, significantly, then we hold, wait for the report to settle, and then re-challenge with a small dose and build it. I think most of the patients settle with the second exposure. So that's the usual, like most of us will do. There is a question which is for Siddharth. Siddharth, I mean, the question was that is it recommended to give prophylaxis of acyclovir, rather than for herpes than just a vaccination with Shingrix? I mean, do we would normally give prophylaxis for most of the usual immunosuppressants?
So this question would have been particularly more relevant in the pre-Shingrix era, where the Zostavax uptake was fairly low because of it being a live vaccine. So with the routine availability of Shingrix, that's the way to go about it. But if there is any issue with availability, there are per se no issues. But theoretically, yes, there is a case for giving acyclovir prophylaxis for prevention, but that's currently restricted to the oncologic settings, post-transplant, etc. Not really routine for the immunosuppressives that we use in your setting or our setting. But yes, drugs like proteasome inhibitors, etc., borrowing from or extrapolating from oncology, we might want to give them acyclovir prophylaxis. But the duration of its use, the dosing, etc., is not clear. So that's an under-evaluated area. But yes, with the vaccine around, I think probably would be not of much scientific interest to look at that. But yes, that's a possibility.
Thank you. I think most of us are not using it in routine. Shruti, would you like to make a comment there?
One exception would be Alemtuzumab. Otherwise, it is exactly as Dr. Siddharth told. Alemtuzumab, we give 1 month of acyclovir when we start the medication. So that's the only exception.
Yeah, because it has a higher risk for zoster compared to the others, I think.
Yeah, that's a recommendation for alemtuzumab.
Okay.
But anyway, it's so used infrequently that probably most of the others are. So the other question is I would give it to, I would request Salil and maybe Shruti can also take up, is that, I mean, I think since ocrelizumab is a more recent, recent part of the armamentarium, and we've been using rituximab in the country and more frequently. But let's say someone wants to transition for a reason from ocrevus to rituximab. The question was about someone having disease, like example given was systemic sclerosis and myositis, and now as an add-on disease, and now they want to shift, considering rituximab may be a more broad spectrum. So I don't know whether ocrevus could still work for these conditions. They are both CD20. But let's say if someone wants to transition, would we follow the same goals that, at the end of 6 months, you just simply transition to rituximab or would there be a separate process? Since Salil, you had covered it, including the other CD20 drugs.
So yes, rituximab, as per the guideline from ocrevus, if you want to shift over, so anything from there needs to be a washout period for that, and 3 months is like what you said is what would be is the recommended one recently. As far as the choice to cover both the conditions go, I guess it would be a good choice, but I really have no data or personal experience to back that, especially about systemic sclerosis. But yes, it would be, logic says that it would be a good choice to go for it. Maybe Dr. Siddharth can chip in with the thing, but probably he'll have more experience related to systemic sclerosis.
Sir, so ocrelizumab, if you look at ocrelizumab in rheumatology per se, so theoretically it should not be very different from rituximab. But with our current understanding of the various rheumatic diseases, we have found fairly surprising results. So it had a negative result in lupus. It has not really been studied in systemic sclerosis or myositis. In fact, if you look at B cell depletion from a rheumatological perspective, we're gradually transitioning from type 1 monoclonal antibodies to type 2. So we've started using obinutuzumab for our refractory patients, and because the mechanistic efficiency of type 2 anti-CD20 monoclonals and the different mechanisms of action, we're gradually transitioning towards that. So ocrelizumab per se does not really have a current standing in these diseases. Where we are headed is more towards type 2 anti-CD20s.
So I think that's pretty much it. I think one has to use experience, wisdom, science, and evidence in such situations. But I think the choice can be based on whatever best works for both, and one may have to change. As I said, as Siddhartha said, the data for ocrelizumab may not be very large, even in rheumatological conditions. And even for MS, it is over the last few years only. So I think the transitioning part, as Salil has said, there could be a short washout and then you could move on to the next dose, next drug. We'll just take these last two questions. It is about, one would be related to a point of view which can be varying, is about, de-escalation for someone like MOGAD who is doing well and 1 year of rituximab. Whether the DMT needs to be switched really. So I think that again depends on how you and the patient both perceive rituximab and its need. But we can take the opinion from the house, Shruti and Salil. So the question is about, whether we should de-escalate if someone is doing well on rituximab, 1 year only of MOGAD.
I suppose it depends upon why we started it in the first place. So if we are thinking that this is going to be a relapsing MOGAD or a highly active or a highly severe disability at the first place, and that was what prompted us to start on the treatment, it is better to continue the therapy. So I personally would continue therapy for at least 2 to 5 years, and there is no real data to back this up. We are just acquiring more and more data on how long to continue MOGAD treatment. And I think there was also a question on whether we would use the serum levels of the antibody. We now know that it is not a good marker to decide on whether to continue or stop therapy. So if the reason for starting therapy was a relapsing disease, it may be prudent to continue it for a longer period of time to be sure that there is no active disease ongoing, but we do not have a definite marker at present to say when to stop. So 1 year may be too short.
So again, I would agree with Dr. Shruti what you said. I'd give two case scenarios. One, since we just had similar things recently. One case, a patient comes with maybe 2 attacks of optic neuritis, recovers completely. We decide to give rituximab. Patient is under good control, and we discuss the patient. Patient is also keen that I should try and get off the drug. And we discuss the pros and cons of this, continuing the drug versus not continuing it. Second scenario is this we're talking about severity of the disease. Second scenario is patient has optic neuritis, has got some disability which is left behind, has got transverse myelitis, has got disability left behind, and is not keen to get off the drug because they don't want to take the risk of a third attack causing complete disability for this patient. And they would also probably edge towards continuing the drug. Another somewhat middle path would be to, if you want to be a little safer, what Dr. Thomas had said in his talk, and which in fact we tried it in some of our patients also, reducing the dose of rituximab, that is giving 500 mg and following it up with regular CD19 levels and seeing, and if it crosses 1%, then you give the patient again. So there is no right or a wrong approach. It depends on what you would like, what the patient would like, and what are the goals for both together, and you can try and get a middle pathway which will help you answer this particular question.
Yeah, I think, please, Shruti, you want to say something?
I just want to tell that specifically for MOGAD, we do not know whether switching from rituximab to MMF is de-escalation. Because we know that for NMOSD, Azoran and MMF are less effective than rituximab. And for MS also, rituximab is quite effective. But for MOGAD, we do not have that data. We do not know whether rituximab is more effective or less effective than MMF. So we cannot call switching to an oral therapy de-escalation yet. So, but what Dr. Salil told is a good way of de-escalation, bring down the dosage or the duration of intervals between the therapy.
Yeah, actually, practically, I think the usual dose of rituximab used is anyway about 500 milligrams, Q 6 to 8 months. And I think for MS, we are more, we give more leeway because we know that the relapse rates are not going to be usually that high, and the diseases are not generally aggressive unless the disease has been aggressive at the baseline. Because NMO and MOGAD are a bit more uncertain related to their timeline for relapses, and we know that in spite of people having CD19 0% at 6 months, and we've kind of sometimes pushed back their immunosuppression because we want to play safe and reduce their overall cumulative frequency. There have been instances where they have relapsed even with 0% cell count. So we are slightly more apprehensive as to how long we should push, maybe a month, 2 months, which is quite average. So I think on an average, a patient would get something between 6 to 9 months on most of us practicing that using your CD20 markers. But since there are tissue B cells and we have other memory B cells, we don't know really what plays in causing a relapse in such patients, including CD27 cells. So as Shruti and Salil have rightly said that, if you've already started rituximab and you've chosen that for a MOGAD patient, and 1 year is not even enough time to even predict the true relapsing nature of the disease, I think it may be prudent to continue and then consider oral unless you have concerns and patient has a concern that they don't want to take a biological because now they are started to think how long. But that generally would not be a bigger question because the frequency of dosing is not going to be very high. Usually, thing. And as Shruti also said, and we really don't even know the really true long-term efficacy of rituximab in MOGAD. There's been always a question about its efficacy in MOGAD compared to the known efficacy in NMOSD patients and MS as well. So there is a bit of a slight question mark there. So I think for the lack of time, we would just take one last question, and that is about someone on rituximab and the lady is planning a pregnancy. So what would be the best way to now look at the whole scenario, and what would we usually guide the patient as to how and when she can plan pregnancy? So maybe Salil and Shruti, you can add on to your comments.
This again, we'll take I refer to the graph which I had shown earlier about the washout period as a build-up to pregnancy. The only monoclonal antibody which we can continue to give right till the end as per this, and there's no data to support this. Let me say that first, there's no clear-cut guidelines on this, but evidence is coming in which says that maybe natalizumab right up till the time the patient is pregnant, one can give it. Anything short of that, it has to be a planned pregnancy. One has to do a clear 3 to 4 month period before the plan, or like in rituximab case, 6 months before you should stop the infusion and then plan the pregnancy. This would be what I would probably go ahead for this patient, and I maybe switch over to another drug if the disease is highly active, or depending on the disease activity, one would go. Or if the disease is so active and I need to change the drug or control it, I would probably advise them to defer the pregnancy for a while, control the disease, and then probably go ahead for the pregnancy, especially since it's a planned pregnancy. I take the views of Dr. Shruti also, and Dr. Rohit, in fact, for the matter.
Thank you. I mean, I also prefer to have at least 1 year of disease control before pregnancy is planned. I personally, I do not like to stop DMTs when they are planning pregnancy. It gives it a kind of urgency and a kind of, they become more worried about not getting pregnant on time. So I usually continue therapy. Rituximab, we have sufficient data that it is not teratogenic. The label says 6 months of therapy before you plan pregnancy, but I think there are good journals which have published, including the Continuum, which says that 2 months is sufficient. So I think it may be with the understanding, with the patient's understanding that this is what things are, we can have a discussion and decide upon 2 months as a time to wait before they plan pregnancy. And of course, rituximab in the second half of pregnancy can cause lymphopenia in the baby, and that has to be monitored and should be avoided. So better avoid rituximab during the course of pregnancy, and then immediately consider starting any one of the agents after the pregnancy is completed. That would be my strategy in general.
Siddharth, any concerns since you are managing rheumatological conditions as well?
So I have, sir, quite interesting things, I would say. This is a very dynamic field. So we use a lot of rituximab. So all of these principles about having a planned pregnancy when there is the diseases quiescent hold true across the set of immune-mediated diseases. But if you look at our setup, the kind of patients we cater to, most of the pregnancies are not planned. And I am not sure about MS and the demyelinating diseases, but a lot of our rheumatological diseases present for the first time during pregnancy, or they flare during pregnancy, so much so that the disease itself may be life-threatening to the mother. So there is enough data on use of rituximab even during pregnancy, and not for planned pregnancies per se, but when the indication is from the maternal aspect and the pregnancy outcomes have been good. So as madam said, that rituximab is not teratogenic. So what we are really concerned with is basically immunosuppression in the baby. And when we are looking at very high disease activity in the mother, and the mother is at an imminent risk of death or morbidity, then there are cases where you would give rituximab even during pregnancy, with the pregnancy outcomes being fine. There would be some alterations in the baby, as in we would avoid live vaccines if the rituximab has been given relatively later in the pregnancy. You would watch for lymphopenia and other things. But that was one thing I wanted to add. Maybe not so relevant for you, because I don't know how MS behaves during pregnancy, but a lot of our diseases, they really just gallop badly during pregnancy.
So I think the good thing about MS and pregnancy, I'm not saying the good thing, but I'm saying a relative positive thing is that majority of the pregnancies do well in MS and the flare-ups reduce. There is always a variation of the data when it comes from different registries, but in general, we know that majority of the pregnancies do well, and the flare-ups are quite less during pregnancy, even in our own experience. And I think the same would be across Salil and Shruti's experience as well. In fact,
that's one headache less for neurology.
Yeah. And I think the one good thing or one drug that we fall back upon when we are dealing with an aggressive disease and we know that we have to tide over the period of 9 months and we want to avoid direct exposure, I think is rituximab, in fact. So I would say that it's the other way around, that yes, giving rituximab during pregnancy is still a bit of a concern, that you don't want to initiate lymphopenia and some direct teratogenicity on the fetus. So normally when a lady is coming to us and let's say she's taken a rituximab an X point of time, then as Shruti rightly said, we ask her to wait for about next 2, 3, 4 months so that there is a kind of a mid-level setup and exposure has gone direct, and then encourage them that okay, they can become pregnant, because then we at least have effect of a drug that is still there, and we can we know we can tide over the next 6, 9 months more comfortably. The biggest challenge is when we are dealing with people with more aggressive diseases like NMOSD and MOGAD, where we are not sure that whether we should expose them for rituximab when it becomes due. So we kind of, keep our fingers crossed, and we hope that patients don't repopulate too high during pregnancy, and we can tide over their period of exposure so that they don't get a direct exposure during pregnancy. But I think there is a lot of heterogeneity about rituximab's true teratogenicity and its adverse effects in pregnancy. But I think the good thing is that MS and pregnancy are probably have a good relationship between each other. So we and exposures in pregnancy directly are generally not required. So we are able to give an exposure, wait for the drugs, slight time window, and then start to plan them for pregnancy. Because even if they're planning, sometimes it takes them 1 or 2 months, 3 months to actually, get pregnant. So that is also a natural process which can vary from one individual to another. So I think that was kind of the take we normally have in our clinics and in practice. If there is anything else which is what you people think, maybe we can. So I think, Salil, you want to say something?
No, I just wanted to say the term planned pregnancy is actually a misnomer. There's
Yeah,
no
of
such thing
course,
as
of
planned
course.
pregnancy.
No, it's a planned
happens,
pregnancy
but
from their perspective, because they are coming and asking us, when do I seriously start to contemplate a childbirth?
like I had mentioned earlier that there is no drug which has what evidence has shown again that there's no drug for which we need to ask the patient to abort because it has been exposed prior to getting pregnant. So almost all drugs are they say that they're safe, they can be given, but not they don't support it, but they'll say
Yeah,
it's safe.
because the data for exposures in the first are very, I mean, the latest, one of the recent papers was one which was published for a registry in Green Journal of Neurology just some time back, where they have looked at clearly. One second. I need exposures, but the period of exposures have been very short, the first 4-6 weeks. It's like very, very close by exposures and the risk. But of course, the overall risk estimates are small. And for some drugs, we know more now. For some drugs, we still don't know enough. We know for glatiramer, we know for interferons, we also know for DMF. We are learning to know for many of the drugs, but you said that majority of the time, the exposures are, if they are short, then the likelihood of teratogenic effect is small because you can immediately stop the medication. The problem is teriflunomide, where we may have to seriously consider. So I think today's webinar was very, very informative. I hope more residents and fellows could know and attend it, because I think we've covered from the drugs to biologicals to management, planning using vaccination, concerns about immunosuppression and vaccination use, the newer vaccination strategies, and then how to consider switching from one drug to the other. So I hope that this was beneficial to the attendees, and I thank you all the speakers for their wonderful presentations and discussion, and hope to see you in one of the next webinars in the due course of time. I thank Asmita and Bhavesh and their team for supporting this webinar and going through this whole process and helping record Dr. Thomas Matthews' talk, which was also extremely important during this whole webinar. So thank you very much, and hope you all have a great weekend.